Obviously with the meeting earlier this year. So yeah, it was just I only went up for the one day.
All right.
So
Good.
yeah.
All right.
Dr. Bassem, can I start, please, sir? We are just on time.
Yes, yes.
Bismillah ar-Rahman ar-Rahim. It gives me a great honor and pleasure to announce for this special webinar, Shoulder, Elbow, Wrist and Hand Specialty Day. It's the final webinar in the course of Specialty Days, and we have started online meetings and educations online since more than 6 years. First of all, I would like to thank all our guest speakers from Egypt, from South Africa, from Germany, from UK. Special thanks to our great professor, Professor Bassem Flega, and my dear brother, Dr. Professor Ashraf Abdelaziz, for their great help and support to complete this very fruitful webinar. Professor Bassem, would you please start, sir? And many thanks to our dear guests from South Africa and our brothers from South Africa. Thank you so much for being with us. Please,
Thank
Professor
you for
Bassem.
having us. Thank you.
Thank you, sir.
Thank you very much, Dr. Al-Ashram. I'm really very happy that we have this meeting with really South Africa and Egypt together with many participants from both countries. And I hope that this will be a start for future webinars for us together and the African colleagues all around Africa. I'm sure that they will be very anxious to join us for the next meetings. First, I want to thank you, Dr. Al-Ashram, and thank Banha University for allowing us as the African Shoulder and Elbow Society to be there. The African Shoulder and Elbow Society is 3 years old. Now we have the president, Dr. Leon Raj from South Africa, and the vice president is Dr. Yasser Safuri from Egypt. And below are the 11 founder executive committees. And we had a lot of success in the past. I hope we will continue also in the future. I will talk actually about my experience in 45 years in rotator cuff repair, transosseous rotator cuff repair, from open to arthroscopic. First, I started my first contact with the rotator cuff problems in 1979. It was in Germany, in Neuwied. And this is where I started my residency in orthopedics. And the first shocking thing for me was that an old woman, 80 years old, she committed suicide from this bridge because she had a rotator cuff tear and she had acute pain every day and nobody could help her at that time. I'll go a little bit in the history. In 1834, there was the first description of a rotator cuff repair by Smith. Then in 1872, Dupré described the term called periarthritis humerus scapularis, which means actually also rotator cuff tear and other problems around the shoulder. And this diagnosis actually stayed for more than 60 years, and every patient were treated conservatively. Till Codman in 1911 made his first operation on rotator cuff, a simple transosseous repair, and he published his series then in 34. In 44, McLaughlin introduced the mattress transosseous rotator cuff repair technique. Till 1972, when Neer came, and he described the impingement syndrome, and phase 3 of impingement syndrome was a rotator cuff tear. And he said that 95% of all rotator cuff tears are due to impingement syndrome, which is a subacromial narrowing, mainly due to bone spur at the anterior acromion or a bone subacromial narrowing. And he classified the rotator cuff tears according to etiology to traumatic tears, which are contusion tears actually, and then acute dislocation tear, which happens in older patients with a tear of the rotator interval and subscapularis, and multi-direction instability tear, which is an open rotator interval. And then finally, the impingement tear or the subacromial narrowing tear, which was in 95% of the cases as he described it. Actually, there are many classifications of rotator cuff tear. The most commonly used classification is according to the size as described by Caulfield, a partial thickness tear or articular surface or bursal surface, full thickness small tear, full thickness large tear, and full thickness massive tear, which is a tear of more than 45 millimeters. Up till recently, actually, there was no classification of massive rotator cuff tear. We introduced a new classification, which is now under publication, and we classify the massive rotator cuff tear into 5 types. Type 1, where there is absence of the supraspinatus and infraspinatus. Type 2, where the absence of the supraspinatus and subscapularis. Type 3, absence of the supraspinatus and the upper 2 halves of the infra and subscapularis. And type 4, where all tendons are absent. Type 5, where there is an osteoarthritis or rotator cuff arthropathy. We introduced in this also in the first 3 types, the B, which is for the biceps tendon, and C for the capsule. This is very important for to consider in treatment of the rotator cuff. The biceps can be used in the reconstruction, as we will show later. And we have to be aware of the inferior capsule. Contraction of the inferior capsule causes the head to this, or subluxate superiorly, so that when you want to repair, it will be very difficult. So in this case, you have to release the inferior capsule. And accordingly, we classify the 3 types into B plus or B minus. Either there is a biceps or there's no biceps, there is a contraction or there is no contraction. So open rotator cuff repair. As we started to do that in the 80s, in the early 80s, when I had a course with Dr. Neer, he taught us to do a subacromial decompression, which was published later in '83. And this is to relieve the cause of the tear and then repair the rotator cuff. The surgery is done with the patient is lying on his back, about 20 to 30 degrees sitting, and a small incision, about 10 centimeter Gardner approach is made. The deltoid will be split where it is inserted at the anterior acromion. Then the lower surface will be freed, and anterior acromioplasty is done, the removal of a wedge resection of the anterior acromion with the base anteriorly. After that, the footprint area will be abraded and made a bleeding surface, and then holes are made in the footprint and a lateral part of the shaft or the tuberosity, and then the sutures are passed through the tendon and in the hole, and the tendon is transosseously fixed to the barefoot area of the insertion, and then the deltoid is closed. Summary of the results of these cases at that time were very, very good. It was considered as the golden standard for treatment of rotator cuff tear. The average results were mostly excellent in most of the cases. The hospital stay was 4 to 10 days, and the post-operative rehabilitation sometimes took up to 1 year. We had also several publications at that time on this technique of rotator cuff repair with subacromial decompression. It was the first publications actually in Germany and maybe also in Europe. And later we made also international publications, several publications, mainly the one which actually made an effect on controversy between the question of how either to repair a larger rotator cuff or massive tear or not repairing it sufficient, we do only decompression, which was the controversy between Charles Nier and Charles Rockwood. So we made two studies. One study, 10 years follow-up of the cases of transosseous rotator cuff repair, which were very good, very encouraging, and also a study on patients above 70 years of age, which actually added to the trend to actually repair all rotator cuff tears as much as possible. The arthroscopic treatment. In 1985, the first arthroscopic subacromial decompression was done by Ellerman. It was done in lateral decubitus position. Then Warren in 1988 introduced the B chair position to do the subacromial decompression. The first rotator cuff repair was done by Lanny Johnson, the first arthroscopic rotator cuff repair. He used stable to fix the tendon. Actually, this was not very successful because of the loosening of the stable or causing impingement problems. In 1989, we started our shoulder clinic in Bonn in Germany, and we did a lot of work in the arthroscopic rotator cuff repair. The first contribution, we modified the B chair position to sitting position so that the shoulder will match the X-ray picture, which is also in the OR where we are doing surgery. And also the arm is hanging in the standard position. So we have a standard position of the shoulder with 0 rotation. And it is also, of course, manipulation free. In 1990, Eugene Wolf have presented his technique of anchor repair, of rotator cuff repair, a single anchor repair. And he published also relatively good results. I really was very keen to do this technique because this technique actually fixes the rotator cuff in one point, and the contact between the cuff and the bone or the footprint area is very small compared to the transosseous fixation, where you have a complete compression of the rotator cuff, the whole of the footprint area, and really a good fixation of the cuff. So we thought to have another idea, and then we use this giant needle technique to simulate the open transosseous repair. It is using this needle to go through the skin, then through the tendon, through the bone, and out, and then tie the suture to simulate the open transosseous rotator cuff repair. The third contribution, that we made a study on 410 cases. We measured the space between the anterior acromion and the tendon with a patient in a sitting position under anesthesia, and we found that there is no rotator cuff repair when the space was more than 1.2 centimeter. So we said, okay, we do a decompression till the space is 1.2 centimeter, and that will be our standard. If the space is already more, so we don't do a subacromial decompression. And then we use this measuring needle, which is also we patented, to measure the space between the anterior acromion and the rotator cuff by putting two needles, one on the medial corner of the anterior acromion and one on the lateral corner. The fourth contribution is to have a sliding compression node, a sliding tying node, one way self-locking knot, and we called it the giant knot. And this knot is used to suture the tendon and compress the tendon to the footprint area. It was published in '99 also. Also, we then invented a concave knot driver, also was patented in order to push the knot inside and place it in the place we want, more superior and more inferior. So through the concave shape of the knot pusher, we can push or put the knot in the place we want. So realizing this problem of that single anchor or single row is not sufficient and has complications, and the technique was modified to a double row fixation in order to have more contact between the tendon and the footprint area. We then went to the many studies were done on this. The most known studies are from Gerber and Bisson, and he showed that the transosseous fixation has a double strength of fixation than the single row and 150% more than the double row. So the transosseous repair is a biological fixation. Many come and ask me, well, when you have the suture, the other one is a metal and it will stay. Well, actually, we are not fixing the tendon with metal or with suture. We are fixing it till the tendon heals in the bone and it's fixed biologically to the bone. So actually, after that, even there is no need for sutures. And I want to say that I did rotator cuff repair in the beginning only with absorbable suture for over 1 year. So the transosseous fixation improve ultimate load to failure, as we said, biological fixation, restore the footprint, and achieve a good compression of tendon to bone. And it is also stable fixation in osteoporosis, which is actually a problem with other techniques. So in arthroscopic repair, we did many publications. Till 4 years ago, there were 33 publications. Now I will just summarize the technique for the participants that don't know it. Actually, with the arm hanging and the patient in a sitting position, we go to the footprint area, as we see here, and we abrade the footprint area with an acromionizer, so to have a bleeding surface. After that, this is an owl. We go with the owl and make a hole at the junction of the cartilaginous head to the footprint area. In this hole, we will pass the sutures, the giant needle and the sutures, and you see the giant needle passing anterior to the anterior acromion, then through the tendon, and it is pushed in the hole. After that, we push the needle through the bone in a stepwise manner. Actually, it passes very easy. Sometimes if you have resistance, we just rock the elbow in and out, and lateral rotation. Then the lower end of the sutures are pulled from the shaft and the upper end, and then the knot is made and pushed inside the joint, as we see here, to fix the tendon to the footprint area. In some cases, like here, we want to repair the infraspinatus. We can't do that with a giant needle because of acromion. So we put the suture first, and then we go with this chop needle puller, as you see on the right, through the skin, through the tendon, and pull the suture then from the bone through the tendon and tie it. This is for the infraspinatus repair. The techniques of repair are similar to the open repair, like the U-shape repair. First, we do a medial end-to-end repair, then transosseous repair. Also for the L-type repair, we first put the ends together and then tie the medial end to end and the lateral transosseous. Mobilization of large tear is very important. We have to mobilize and take our time to mobilize the tendon from below and from above, and until we get the tendon to reach the footprint area in maximum 25 degrees of abduction. More than that, it will have tension and it may we may have failure of repair. The mobilization, many steps. The first step is to clear all adhesions from bursa and from the superficial space surface. Then we detach the glenohumeral joint capsule from the rotator cuff and leave it in, with the tendon. We divide the coracohumeral ligament and detach of adherent supraspinatus. And then we repair the tendon. Here we see a case of large tear. Actually, it is after a failed ankle repair, and after the ankle removal, you will see the medial placement of the end-to-end sutures and then the transosseous sutures in between the holes of the anchors. In massive tear, also, we use the biceps. That's why I said the classification, is there a biceps or no biceps? As the biceps is used in the open repair, we use it also now in the arthroscopic repair with the new technique. You see the long head of the biceps from its origin, the glenoid, to the tendomuscular junction is about 9 centimeters. So we use the upper part of this tendon by tenodizing the biceps tendon to the greater tuberosity, and then the medial end to the remnants of the supraspinatus, while the lower half we can use it to the subscapularis or even to the infraspinatus. This is also the advantage actually of the giant needle. We go with the needle medial to the AC joint and the posterior to the clavicle in the so-called Nevisor approach, and we go with the needle through the stump or the remnants of the supraspinatus, and then through the biceps tendon. And then that's after tenodizing the biceps tendon in the greater tuberosity. Then the tendon is sutured and tied to the biceps after releasing it, of course, from the glenoid. So we have dynamic or supraspinatus dynamic reconstruction. We have used this surgery several times now, and actually the results are very promising. We see here on the left side, this is a case of about 60 years old, 55 years old patient with a very massive tear. There is only the stump of the supraspinatus is available. The biceps tendon was there. So we released the biceps tendon, made here a tenodesis, and sutured the biceps tendon to the remnants of the supraspinatus. We see here on the MRI that's before surgery, there is no tendon at all above the head, and this is after surgery. And we see here also in this position preoperative, above the head there is nothing, and there is the biceps tendon here above the head after fixation postoperative. This is the patient preoperative. He was not able to elevate the head more than 30 degrees. And when we asked him to forcefully try with all his strength. He was not able to just push the arm above. And on the right side is the same case 3 months after surgery. And now he is even elevating 1.5 kilo. He improved even more after that time. So the most important thing in this technique is the cost factor. Actually, we made a study in our hospital. We found that the cost of $1,000 for the giant needles for the 100 surgeries is equivalent to $54,000 in cases of usage of anchor. So there is a very, very great advantage in this. So finally, why I use arthroscopic transosseous joint needle rotator cuff repair? There are 7 reasons. First, the cost, as I showed before, it's about 95% less than material cost than other technique. It is a biological fixation, transosseous biological fixation. It is a painless procedure. The patient can use the arm immediately after 1 or 2 days from surgery, while the other technique, he has pain because the anchor moves in the bone till it is fixed and the bone is grown in it and fix it. So that's what all the physiotherapists told me, that there's really a very obvious difference in that. The revision, of course, you have still the bone stock, and you can have a good revision in this case, and also use it in revision of anchor cases. It is also usable in osteoporosis, and there's no complications of hardware, and the results are 70%, more than 70% excellent results. Thank you very much for your attention. And I want to thank also again Dr. Al-Ashar for his great effort. Thank you.
Thank you so much, my dear Professor Bassem, for this very interesting presentation. If we have any questions to Professor Bassem. I think we don't have questions in the chat box or in the question and answer box. Thank you so much, sir. So we have to move to the next speaker. Professor Bassem, would you please introduce our next speaker, sir? Professor Rashun from South Africa.
I have problem getting out. I want to.
I think he's not with us, Professor Rashun and Professor Greff. They are not with us, I think, Dr. Bassem. We have Dr. Osman and Dr. Mike Mulder.
Okay. Maybe Doctor, we have Dr. Osman now?
Yes.
Okay.
We can shift to Dr. Osman.
Yes,
and then
may
Dr.
I?
Mike Mulder.
Okay, I have the pleasure and honor to present Dr. Osman and to talk about tendon transfers at the shoulder for irreparable rotator cuff tears. Actually, a very good subject after my subject. Please, Dr. Osman.
Thank you, everybody, and thank you so much for inviting me to your meeting. I'm trying to screen share at the moment.
Professor, yes, please.
Do you see that?
Yes, sir.
All right. So if we can, I'll see that I can start. Let's look at tendon transfers for irreparable rotator cuff tears. Professor Flieger, your presentation is amazing. You've been doing this for a long time, so but sometimes we cannot get the rotator cuff to heal, and that's from biology. We've become good mechanics, but we still don't know the biology for rotator cuff repairs. So if we have a massive rotator cuff tear, the classification I've used here is Collins classification, who described tears, massive tears as combined tendon tears, where they're associated with supraspinatus or anterior subscap tears or supraspinatus and posterior rotator cuff tears. So these tears can, of course, be difficult. They will eventually, of course, if you don't repair them, will lead to muscle fatty infiltration, muscle wasting and muscle loss, tendon degeneration and tendon loss with retraction. And this becomes irreparable. And left alone further, these would invariably lead to cuff tear arthropathy. So why would we consider tendon transfer? We know that young active patients in this group of patients, young active patients require pain relief, range of motion, but more importantly, they require strength and function. And they also require a balanced force couples, which will delay degenerative changes progressing. We also don't know what happens with reverse shoulder arthroplasty in young active patients. And therefore, these are a selected group of patients that we may want to consider some other alternatives. To understand tendon transfers and the shoulder function, we must understand the biomechanics of the shoulder. And there are essentially two force couples that are so important. The vertical force couple is the deltoid, which allows for abduction and superior force up to the humeral head. But the supraspinatus and the lower subscap provides an inferior directed force. So they balance up the vertical force couples. With the horizontal force couples, we have the anterior rotator cuff and posterior cuff, which is the subscap and infraspinatus teres minor. And these balance the shoulder in horizontal direction. So we have basically a vertical direction versus a horizontal force direction. So if you have a loss of any of these muscles or tendons, this would lead to loss or abnormalities of the force couples, and therefore you get unidirectional or bidirectional weakness in these cases. So it's very complex to understand. You have a patient who comes in with a big cuff tear, and we get confused by all the different types of tears that are occurring at the same time. So when you're looking at these, this is a simplified way of trying to understand how you're going to restore these force couples in these patients. So we know of all these lag signs, Job's drop-arm test for supraspinatus weakness, the hornblower test for teres minor and infraspinatus weakness. The lag sign at the arm of the side will be infraspinatus weakness. And of course, lift-off test for subscap weakness. So if you assess the patient in this direction, you'll be able to identify where the predominant weakness is in this patient. So we end up with this kind of clinical presentation. Patient comes initially with painful loss of forward elevation. This is called PLEA, described by Pascal Bolo a while back. This is due to a full thickness retracted supraspinatus tear, and these patients have pain mainly on overhead activity. And when you test them, they have a positive Job's drop-arm test. In this case, they have an intact horizontal force couple, but there is a loss of the vertical force couple in these patients. In these patients, we would consider doing a lat dorsi transfer, because if you look at the slide on the right, the lat dorsi goes in a much vertical direction compared to the lower trapezius. And therefore, if you transfer the lat dorsi to the superior part of the humerus, you will basically create an inferior directed force, which then counteracts the force of the deltoid. What if you have an isolated total active elevation deficit? This is different from the painful one we spoke about now, because this is a true pseudoparalysis. Burks has classified a true pseudoparalysis as forward flexion less than 45 degrees. And this is essentially a loss of the vertical force couple. And for this element of pseudoparalysis and weakness, this cannot be managed with a tendon transfer. And in this case, a reverse total shoulder replacement is probably indicated. The other type of presentation would be an isolated loss of external rotation. This is either with the arm at the side or the arm at 90 degrees of abduction. If the arm is at the side, you have a positive external rotational lag sign. And for this, the old technique of doing a lat dorsi combined with a teres major transfer, which is called the lepiscopo, this is be indicated, or you may consider a lower trapezius transfer. And I'll come on to these at a later stage. If the arm is at 90 degrees abduction, where you have weakness, but reasonable weakness at the side, in this case, a lat dorsi transfer is more likely to be indicated. If you have an isolated loss of external rotation, like I've explained now, but you have a very strong posterior deltoid, then with the arm in abduction, this patient will have external rotation and be able to maintain that external rotation. So with this, all we're going to do is transfer a muscle from the back onto the posterior part of the humeral head And for this, a lower trapezius transfer is probably the more relevant indication. Why do you need external rotation? You can see there's multiple reasons for having the use of external rotation, and becomes a huge disability if you don't have it. The other clinical presentation was then described by Jean Carny, and this is looking at internal rotation problems. If you have a combined loss of elevation and external rotation, which is bidirectional, loss of forward flexion, loss of external rotation in two directions, this is a combined massive tear of supraspinatus and the posterior superior cuff. This leads to loss of horizontal and vertical and horizontal force couple loss. For this, you cannot replace two functions by a tendon transfer, and therefore you need to do a reverse shoulder replacement. And because of external rotational loss, we probably would want to add a lat dorsi transfer. Jean Carny then described the problems in front where you had isolated loss of internal rotation. This is called ILEA. In this, you had a complete subscapularis tear where you had a positive clinical signs and positive lag signs. This is a unidirectional loss. And for this, a pec major or a lat dorsi transfer has been described. If you have a complete loss of elevation and internal rotational loss, where you have bidirectional weakness, in this case, you have a combined supraspinatus and subscap tear. For this, a reverse shoulder replacement with a possible lat dorsi transfer is indicated. So, what are the principles of tendon transfer? Firstly, the donor site must be expendable. It must have a similar excursion to the recipient site, must have good strength. And we always transfer one tendon for one loss of muscle function. Also, the line of pull of that must mirror the recipient muscle, which means it must be synergistic with that muscle. So if you look at lat dorsi transfer, which is what is originally described for birth palsy, Gerber initially demonstrated using the lat dorsi transfer using a two-incision technique, one for the harvest and one for the superior cuff, where we would do an osteotomy of the acromion to transfer the lat dorsi. His results showed improvement in pain. There was some marginal gains in strength recovery, which was more in the females, but less in the males. So if you had an associated subscap tear and did a lat dorsi transfer, these patients had poorer outcomes. So if we look at the anatomy of lat dorsi, we know it arises from the thoracic and spine, and it's a long, big muscle, which then has a large area of origin. It inserts into the anterior part of the humerus, is therefore serves as an adductor and internal rotator of the arm. If you want to take a lat dorsi, I normally place the patient in the lateral decubitus position, feel the anterior part of the scapula, because the lat dorsi lies right in front, right at the most anterior part of those scapular muscles. Once we've identified it, we separate the lat dorsi from teres major, we protect the neurovascular pedicle, and try and do this internal rotation, because if you do it in flexion, you bring in those axillary and radial nerves in close contact. We also try to release a bit of the lat dorsi from the scapula. But at this point in time, you need to protect the neurovascular pedicle. Anterior release then of the lat dorsi is done from the posterior incision. And this is done with the arm in internal rotation. Remember that the radial nerve lies close to the anterior border and the axillary nerve lies on the superior border. So these nerves have to be protected in this part. And this can be not always easy to achieve. But the tendon is released off the humerus and then prepped up. As I mentioned earlier, Gerber used a two-incision technique, whereas Habermeyer used a single incision technique from the back. And in Habermeyer's description of lat dorsi transfer, he inserted the lat dorsi onto the insertion part of infraspinatus. So this did not cover the whole of the supraspinatus footprint. And what is also described is that if you stretch the lat dorsi all the way to the front, the chance of re-rupture is higher. And the functional gain by putting onto the infraspinatus footprint achieves the same forward flexion strength as you would if you put it on top of the humerus. So, of course, from this, we developed arthroscopic assisted or complete arthroscopic techniques. And the advantage of these techniques is that you don't take off deltoid. So we would do an open harvest of the lat dorsi, and then do an arthroscopic transfer of the lat dorsal between deltoid and the infraspinatus. Sometimes you find that the tendon may not be good quality, and for this, you may want to add a graft to the tendon itself. In this case, you can see a marker so that you can actually see if the graft has failed on an X-ray post-op. So what are the results? Namdari described this in 2012 on a multi-center study. He looked at 10 studies, follow up for an adequate number of time. Definite improvement in constant scores and marginal improvements in forward elevation. But what they did find that if you had an associated subscap tear or advanced teres minor atrophy, these led to poorer outcomes. So therefore, what are the indications? What are the contraindications of doing a lot of transfer? If you have bidirectional weakness, absent subscap, atrophic subteres minor, and of course, if you had advanced arthropathy of greater than 3 Hamada classification, if you have a patient who's not compliant to post-op immobilization and muscle re-education, of course, if you have patients with deltoid or nerve palsies, these are definitely an indication to reconsider your decision. The new baby on the block was being described in 2007 from Al Hassan, and for this, he advocated a lower trapezius transfer. And the reason for this is that he found that the function of this was as a scapular retractor, but it had the same line of vector of contraction to the infraspinatus. Therefore, it has a synergistic function. And you can see in the slide on the right that the infraspinatus and teres minor have a very similar line of synergism. So the harvest of this is the lower trap is based and attached to the medial inferior border of the scapula. It lies very superficial. So when you make an incision in this area, be careful that you don't cut into it. Once you identified the scapula, you identified the triangular insertion or tendon of the lower trap. We do mobilize of the scapula, but be careful of the nerve lying 2 meters to the border of the scapula. And because we know we're adding a graft, there's no reason to dissect too much off the medial spine. It does require an elongation of the graft. We usually use an allograft Achilles tendon. It was initially described by doing a 2-incision technique with a deltoid takedown, but this has been improved over the years by doing an arthroscopic assisted technique. For this, we initially we initially dissect out the lower trap, create a tunnel between the deltoid and the posterior cuff. The graft is then passed into the humerus through this hiatus you created. It is then fixed on top of the humerus. Once that is performed, and then I usually prefer an anchor anteriorly as well as two posterior anchors applied medially and laterally. This gives you a secure fixation of the graft. The graft is then retracted posteriorly, split into two, and is sutured to the lower trapezius with the arm in abduction and external rotation using a pulvertuft weave. The arm is then, Allison described his outcomes for lower trap transfer. And he looked at 33 patients, and significantly, nearly all of them had improvement in their scores. And they did recover active forward flexion, external rotation, and abduction. But the prerequisite to get these functions is that you must have a preoperative greater than 45 to 60 degrees of forward elevation. Sometimes, of course, depending on the area you're in, allografts that we can get from a bone bank is not subject to availability in some countries. The quality of these tendons may be suspect. There are, of course, adverse events like allergies and infection to these. So Valenti described a technique using a hamstring autograft. So you got a semi-T tendon, double it up, you add up to 10 centimeters of length, and you use a similar technique that is described for the lower trap, except that you're using a hamstring. And in this, he showed significant improvements of patients with clinical signs that were good for the transfer. Post-op management for those, both lat dorsal and lower trap, is that the arm is immobilized in abduction and neutral rotation for up to 6 weeks. There's a graduated strengthening program following this. Remember, if you do a transfer of the lat dorsal from an internal rotator, it's now become an external rotator, so therefore this requires muscle re-education. Kani then described the problems in front of the shoulder, and for this if you had a complete subscap tear where it's unidirectional, we talked about doing a pec major lat dorsal transfer. So if you have complete loss of elevation, internal rotation, bidirectional problem, this requires a reverse with a tendon transfer. If you look at the pec major, this was originally described, this technique was described in 1997 and reported by Hirsch in 2000. We could use this clavicular or the sternocostal head. This is big dissection anteriorly where the pec major is dissected. You can then pass the pec in front of the coracoid or posterior to the coracoid. Results showing here a large muscle transfer, taking up a lot of space underneath the coracobrachialis. Be aware of the musculocutaneous nerve. But what we did find, the results did show improvement of constant scores. Pain was the biggest improvement in these conditions, but the strength recovery was poorer and deteriorates with time. So this wasn't ideal. Also, the pec major, if you had to convert to further surgery like a reverse, there was extensive dissection now and scarring in front of the shoulder. So Bassam described possibly using the lat dorsi. If you look at the lat dorsi, it once again has a similar direction of the line of the subscap compared to the pec major. If you look at the slide on top, the pec major is almost at 90 degrees, whereas the lat dorsi follows the same line as the subscap. So it's a synergistic internal rotator and therefore may be considered for transfers to subscap tears. And you can, if you mobilize adequately, you can actually transfer the lat dorsi to a more superior position on the lesser tuberosity. This can be done either open, arthroscopic assisted, or arthroscopic. And I kind of initially started doing an auxiliary incision to mobilize the lat dorsi, and then the transfer was done anteriorly. But now with advanced sort of understanding, you can achieve reasonable dissection from the front and can do this all arthroscopic. One of the problems with the lat dorsi is that the tendon is quite small, and therefore that's one of the sort of one of the sort of failures or problems with doing this technique. Although the muscle itself is very strong, and therefore it's still considered as an option. So we did find that the lat dorsi versus pec major, we found that there were improvements in both kind of groups of patients. No progression of OA, but strength recovery with better lat dorsi. But the short-term results, the lat dorsi transfer, of course, is less invasive as the pec major transfer. So in summary, tendon transfers can improve pain and function in young active patients and may delay the need for joint replacement. And as newer techniques of transfer show encouraging delays in developing OA. Decision-making should be done on the loss of the Ford couples, whether it's unidirectional or bidirectional. Know that one tendon can only be transferred for one loss of muscle function. In summary of these conditions we spoke about, painful loss of active elevation. This is a supraspinatus tear. You have an intact horizontal, but if lost of vertical force couple, for me, a lat dorsi transfer is indicated for these patients. If you have an isolated total loss of active elevation, with a true pseudoparalysis, a reverse shoulder replacement is indicated. If you have isolated loss of external rotation, you may consider lat dorsi or low trap transfer for these patients. And if you have if you have an intact posterior deltoid with loss of weakness and external rotation, then just a low trap would probably be the ideal solution. Combine the loss of elevation and external rotation. Once again, you need a reverse shoulder replacement because this is a bidirectional problem, and consider a lat dorsi transfer to regain external rotation. Complete loss of or isolated loss of internal rotation with complete subscap tear. For this, I would probably consider lat dorsi transfer because it's easier to do without so much of dissection, and the results are pretty much equal to pec major. And complete loss of elevation with internal rotation, loss bidirectional problems. Once again, this requires a reverse shoulder replacement and possibly a lat dorsi transfer if you believe in repairing the subscap for reverse. Thank you for your attention.
Thank you so much, sir, Dr. Osman, for this interesting presentation. We have many questions. I think the first question is to Professor Bassem from Dr. Mohammed Habib. Professor Bassem, if we do not have a giant needle, can we use normal needle?
Sorry. No, actually, it is impossible. This is really a special needle. It is made with a special material and also in a special way. Even large needles, which are normal, large needles, they don't work. This is a needle actually to go through the bone. Normal needle, you have to make entry and out holes, outlet holes. So you have to do a mini open with a normal needle, but not arthroscopic.
Thank you, sir. We have two questions to Dr. Osman. The first from Dr. Leon. Please describe your post-operative immobilization following lower trapezius transfer.
Yes, we want to maintain external rotation. So therefore, you keep the arm in neutral, not in external rotation for me. So I would obviously use a kind of rigid brace to keep the arm in abduction, in neutral rotation. Philippe Valenti, though, believes that these patients should be put into a spica cast to maintain that position. So I think the French people are a bit more tougher than we are. My patients don't seem to want to do that. But if they're careful, they can still keep them in abduction brace in neutral rotation. But when you do the transfer, the arm must be in external rotation and abduction, at 90 degrees external rotation, abduction, to make sure you have adequate tension at that time.
Yes, sir. Another question from Dr. Mohammed Habib. What's better in recovery, latissimus dorsi transfer or hamstring tendon in massive tear? And what's the appropriate age for tendon transfer, sir?
I think there's about 3 questions there, but I'll try to answer them. The appropriate age for tendon transfer, we're looking at younger individuals who want to regain strength. So we're looking at an active man who's working, employed, probably a laborer, and he's less than probably 50, and he wants to get strength. And as I mentioned in my opening remarks, if you do a tendon transfer in a young patient, we don't know how long that's going to last. If you do a reverse in a young patient, we're not sure how long the reverse is going to last with the demands that patient puts on. So once you've done a reverse, you can't go back and do a transfer. So you're stuck with the reverse. Once you do reverse, you have to revise by reverse. So tendon transfers, if they are willing to, the patient, you have to discuss with the patient. If they're willing to sit for 6 weeks quietly, don't use their arm, and then spend the next 3 to 6 months rehabilitating this, with the chance that they will get good function, this is the thing that you need to discuss with the patient. So definitely a lat dorsi transfer or a lower trapezius transfer, they're done in younger patients, and in those patients, they have no arthritis. They have weakness, which is their main loss of function.
Yes, sir. Thank you, sir. Professor Bassem, I think we have the whole team of our dear guest speakers from South Africa are attending with us. So we can go back to our schedule, or what do you want, sir?
I would call Dr. Grief to talk about shoulder replacement. What can we do? And after that, we have 2 presentations on dislocation.
Thank you, sir.
Dr. Grief. Dr. Big is mute.
Can you
He's
hear me at
unmute,
this
sir.
stage? Hello?
Yes,
Hello, sir.
we hear you.
Okay, thank you so much. I'm sorry for this. I'm still currently in my, I'm on holiday and in my very remote coastal town in South Africa. So hopefully the Wi-Fi will last this whole presentation. I'm going to talk on total shoulders, what can be expected, a little bit be of a philosophical approach, but also giving some strict advice. For those who don't know where Bloemfontein are, you can just Google center of the universe and you'll just find us a little bit off center from there. I did act as a consultant before for Arthrex, but currently not. I'm going to concentrate on the osteoarthritic shoulder with the intact cuff and not going to open a can of worms regarding fractures, sepsis, and such. This talk will be given in a narrative presentation form while grounding each storyline in a meticulously researched data to ensure a balance of storytelling and empirical evidence without deep diving their specific publications. Malcolm Gladwell has made us aware of the power of the overstory in his book, Revenge of the Tipping Point, regarding a specific subject, how it can influence your philosophy and decision on a specific topic without realizing it. Slowly, this overstory can slowly infiltrate your subconscious and also influence.
Sir, would you please share your screen, sir? It's not working.
Is it better now?
Not yet.
Oh boy. Okay.
The green share button.
You open your screen, sir, and you press on the green one.
Can you hear me on my remote?
We can hear you, but we cannot see the presentation, sir.
Oh, okay. I'll try again. Let me try and sign in again. Hey, I'm sorry. I'm in a very remote town, and the Wi-Fi seems to be a bit of a problem here.
If it is not working from your side, you can send it to Professor Bassem. He will send it to me, and we can make the presentation from our side, and you can say your command. Okay?
Thank you. Okay, thank you.
Okay. Send it to Professor Bassem, please, and please, sir, send it to me.
But he doesn't have my contact.
Oh.
So maybe he sent it to Leon to.
Okay, we can go to the next speaker till we solve this problem, sir.
Yes, I think we can continue with the dislocation part. So I have the honor to call Professor Rauschun to talk about management of chronic shoulder dislocation. And I'm honored to present him for his first talk in our African society. Thank you. Please.
Thank you so much. Thank you for the welcome, and apologies for being slightly late. My clinic just went a bit longer. Just confirm you can see my screen. Awesome. I'm gonna just go into a slide mode. Okay, good. So first, thank you for the invitation to give this talk. This talk is basically based on my experience on chronic anterior shoulder dislocation, and based on our publication and what we have learned from previous cases that we have had. As said, I'm based in Pretoria, South Africa. I work at the University of Pretoria, Steve Biko Academic Hospital. So, although it's very uncommon in literature, chronic anterior shoulder dislocations are very common in my practice. We see pretty much these cases regularly. Just today, we had one case, and on Monday, we operated another case. So this is a daily thing for us, and I'm sure it's a daily problem for most people in Africa. And if you can, as you can see, unlike what is being reported in literature, majority of the patients that we see, there's quite a variable in age group, mostly involving young, active patients, which is contrary to what has been presented in the literature, where they mostly report older patients. And the management of this patient is quite difficult, especially the decision making on what to do for this patient is quite difficult. There's not much of literature to guide you on what to do. Pretty much every procedure that has been described is being described with poor results. So just going back to the definition of chronic shoulder dislocation, this is really poorly defined in literature. If you look at what Goga described, he defined it as a dislocation of more than 1 week. And Rowe and Zarin, they use the mark of 3 weeks. And Gray, both Goga and Gray, from South Africa, Gray used a mark of 2 weeks. But I think the consideration here, well, maybe going to the consideration, Goga further classified this into 3 and said there's early chronic dislocation, which is less than 3 weeks, but over a week. Late chronic dislocation, which is over 3 weeks, but less than 12 weeks, which is quite a broad period, and a lot happens during that period in this patient, in these patients. And then he spoke about an ancient dislocation, which is over 12 weeks. So, but I think the considerations here for me is, I sort of agree with the definitions, but for me is if you're less than 2 weeks, I think there's still a room to try close reduction in these patients. And only if they failed close reduction, then you must consider is it a lock dislocation or they started forming fibrosis already. And beyond 2 weeks, I think there's a lot of complications with a close reduction. Even if you achieve it, you run a risk of neurovascular injuries. And maybe we should be staying away from trying close reduction in these patients. So what to consider, what really happens when this shoulder remains in a dislocated position for so long? So the first thing is you have soft tissue changes that happen. You have capsule contracts, you have extra-articular fibrosis, and you have intra-articular fibrosis and extra-articular adhesions. We already have labral tests and the labrum atrophies. We have rotator cuff tests, especially in the old patients, also that retract and atrophies. And we have they usually have associated long head of biceps tears and the slap tears. And in a long time, they have loose bodies. And also have bony changes, and this really makes the management really difficult. So you get changes on the clinoid side, and the big problem on the clinoid side, especially beyond 4 weeks, is they start forming pseudoclinoid there because the head is sitting there for so long, and they're beginning to use that arm. They're having less pain in that position, and they're beginning to use that arm. But what happens is because the head is outside in an extra-articular space, we get softening of the articular cartilage and softening of the head. The heel sacs begins to get larger, and some of these patients tend to have associated greater tuberosity fractures, which malunite in that position and make the management decision-making quite difficult. So why, first, I think we should check, why do these patients present with chronicity? So a lot is mentioned in literature. Typically, these are patients that delay with presentation, and we see this in alcoholics, epileptic or seizure disease, or patients with multiply injured or psychotic patients. But we actually looked at this in our patients, and majority of the patients that we treat in our center is, majority of them, they actually did visit a doctor or some form of a healthcare center at the day of the injury, but the injury was missed. And this, I think, this is a big problem that we should focus on in trying to tackle this problem. The injury was missed at the day of presentation, or the patient was the referral was delayed to a center where this patient can be managed. Also, we have identified lack of orthopedic surgeons in many rural provinces, or lack of theater services in many rural provinces where this patient often come from. So just from our study, almost half of the patients were missed. They all presented to a healthcare center at the day of the injury, and the injury was missed, resulting in chronicity. And majority of the patients in our study were from the period of COVID. Maybe also the healthcare systems were compromised at that time, but we still continue to see these cases to date, and in large numbers. So we can't really blame it on that alone. So what are the treatment options when you have these patients? They talk about skillful neglect, and really here is about your patient selection. So patients with uncontrolled seizures, you really should shy away from operating on these patients. They tend to do poorly. Patients with uncontrolled psychosis, but also just low demand patients and patients with less pain, with good function, we should really shy away from operating on this patient and leave them alone because we may make them worse. But more importantly, if there's no one in your area with a skill to operate these patients, rather treat them conservatively because surgery can make them worse than treating them conservatively. But in my decision making on who I'm going to operate surgically, usually the high functional demand patients or patients that poorly tolerate the symptoms associated with the chronically dislocated shoulder. So poor function and persistent pain. Those are the patients that I'll operate on. But I think it's important to explain it to the patients before you take them to theater and tell them what is the reason you're operating them and what are you hoping to achieve out of that. Because you will never really get this patient a normal shoulder again. You just need to explain to them that the aim of the surgery is to improve their function and to reduce their pain level. Even with that, there's still a risk that these patients may still be worse off after the surgery. But this is a decision that you don't take alone. This is a decision that you take in discussion with the patient and the patient support system. So pre-op management of this patient. So as I correctly said, your patient selection is very important. You need to run all those other things. You need to address whatever social problems that they may be having that might have led to this chronicity. You need to control the seizures. If you look at every single study in a patient with a shoulder instability or shoulder dislocation who did poorly, it's because they had a seizure after the surgery. It was not because of the surgery, it's because of the seizure. So seizure control in this patient is very important. Whatever medical conditions they have, we need to optimize the medical conditions they have and the psychiatric conditions they have. You need to assess for harm versus benefit, especially when you have patients with what is often referred to as a subclavicular dislocations. The risk of vascular and brachial plexus injury in those patients may be a bit higher than your subcoracoid or your subclavicular dislocations. Frail patients may not benefit from surgery, so those patients you should stay away from. Always start with standard X-rays as always. The big problem here is the bone loss. So standard AP laterally modified axillary view. I don't think you should really be trying to operate on this patient without a CT scan. You really need to know how much bone loss they have, and you need to quantify that bone loss. So a CT scan is really a must before you take this patient for theater. So what are the surgical options available to you? You can do a joint preservation surgery, which is what I'm going to report on from our study, but you can also do a joint replacement. Joint preservation surgery, there's a lot of procedures spoken about in literature, but if you just bring them together into one, all of them is an open reduction, and I'm going to do a soft tissue repair. And soft tissue repair is mostly rotator tear that is repaired, or do have some form of a bone block, either a lateral J or a iliac crest bone block. And Boga et al. Reported on 10 patients that in addition to the lateral J procedure, you put a K-wire fixation for a couple of weeks from the acromion into the humeral head to keep the head there, because these patients tend to have persistent subluxation of the humeral head after you have reduced them. There's a lot reported on reverse shoulder arthroplasty, very few studies on hemiarthroplasty, but a lot of reported on reverse shoulder arthroplasty. And what you get in literature is that patients treated with reverse shoulder arthroplasty for chronic shoulder dislocation, they tend to do poorer than patients treated for calf tear arthropathy or glenohumeral joint osteoarthritis or irreversible calf tear. And this also is related to the complexity that you face in the treatment of these patients. So what to consider before going to theater? So first, this is a difficult procedure. This is not a procedure for just be done by someone who doesn't do shoulder surgery regularly. For someone who's familiar with shoulder surgery, this is a very difficult procedure. You need to consider that there's extra-articular adhesions and muscle shortening. And your pec major is usually shortened as the arm has been sitting in A reduction for long. There's marked fibrosis along the long head of the biceps and along the conjoint tendon. Latissimus dorsi tendon is also shortened in that position. So you need to address all those things. You have subacromial fibrosis, subdeltoid fibrosis, and intraarticular fibrosis that you need to address as well. The subscapularis also may be shortened and quite tight as well in most cases, which is going to be an obstacle for you to be able to reduce this. The second thing is clinoid bone loss. They tend to have severe clinoid bone loss, unlike what has been described in patients with instability. And to add to this, they have a pseudoclinoid that's sitting far more medial than that you need to address as well. The humeral head, they have large Hill-Sachs lesion, but more difficult in dealing with this is that the head gets softer. The softening of the head and there's chondrolysis. You must also take into consideration the proximity of the axillary artery in this patient and the proximity of the brachial plexus. It's literally just there. The head is literally sitting posterior to those structures. The only layer between those structures and the humeral head is the subscapularis, especially in a dislocated position. So it's just there. So if you're not familiar with this, you're going to end up with a patient with a vascular injury and brachial plexus injury. So we recently published on 34 patients that we treated in our center in our local journal, and I'm going to report on those patients and our experience in this presentation. So from this group, these 34 patients, we divided them into two groups: those which we treated with a bone preservation surgery, and those which we treated with a arthroplasty surgery. So from my training, we really trained to shy away from hemiarthroplasty in a chronic anterior shoulder dislocation because we're told that it's doing badly. So I do not have any experience using hemiarthroplasty in these cases. I do have experience in using hemiarthroplasty for posterior shoulder dislocation. But for anterior shoulder dislocation, I tend to shy away from hemiarthroplasty. But in our experience, we have had patients that we treated with a bone block and we subdivided them into lateral J and Eden Habinet procedure. And really, we're guided for on our decision making, we're guided by amount of bone loss, but not only that, but also by the duration of the dislocation. And I'll demonstrate that in the later slides. And we had 7 patients that we treated with a lateral J, with a mean age of around 23 years. And we had 9 patients that we treated with the iliac autograft. All the patients in the iliac autograft were males. They tend to have higher bone loss, and the duration of a dislocation was slightly longer than the entire group. So these patients also required some additional procedure at the time of the surgery. As I said, this tends to be quite complex. So maybe just before talking about the additional procedure is a matter of how we go about this. I tend to rather keep the subscap in place. I don't remove the subscap at all. I will access, after I've removed all the extra articular adhesions, I'll access the joint through the rotator cuff interval. And it's easy to find even in a dislocated position. Find the coracoid, the lighthouse of the shoulder, and you go there, you can get right superior on the base of the coracoid, right on the superior edge of the subscap. That gives you access into the joint. You need to access all that tissue there, and that gives you access into the joint. Okay, and then clear up all the intra-articular fibrosis. The reduction must be easy. It must not be a forceful reduction. If it's a forceful reduction, I can tell you, in the morning when you do a control X-ray, that shoulder is out. So the reduction must be easy. So only if the reduction is not easy, I would rather do something on the subscap. So at the beginning, I started doing a lesser tuberosity osteotomy, but what I've seen with the lesser tuberosity osteotomy is that tuberosity almost always resolved. And these were the patients that end up with some form of head resorption. So since this experience, I've stopped doing that. Now I just do subscapularis stenotomy and I do subscapularis lengthening if I can reduce this. Then after that, I'll address all the other issues. I find the patients with the GT or greater tuberosity malunion easy to manage because this, you just go and do greater tuberosity osteotomy and then you can access the joint through that osteotomy and can clear off all intra-articular adhesions, then reduce the shoulder and then fix the GT bed. So in our experience and in our study, we had 1 patient that we needed to do a subscapular stenotomy and 4 patients that needed lesser tuberosity osteotomy. We had 3 patients who came with the GT malunion that needed to be accessed through there, and 1 patient had a associated rotator cuff tear that we repaired. So those were the patients with the lateral J, that underwent lateral J. Then we also had a group that we treated with a soft tissue repair. So if the patient had an early dislocation, as defined by Boga, and at the time of the surgery, we found that they had massive rotator cuff tear. These were the patients that we treated with the soft tissue repair. And the soft tissue repair included rotator cuff tear in all of them. A third of them, we added a labral repair. If they had a huge or a large heel sex, we will repair the rotator cuff into the heel sex, sort of giving us a rainbow such. And we had one patient that had a significant head that we needed to repair as well. And then the last group is the group that we treated with the arthroplasty. And these were mostly elderly patients over the age of 60 with massive bone loss and ancient dislocations. So in this group, we had 11 patients. And if you just looking at the Quagga classification and how we actually treated our patient, you see that majority of the patient with an ancient dislocation is either they had an Eden hyphenate, or a majority of them actually had an Eden hyphenate in the joint preservation procedure, and a few of them will have a latter J. And then if they were elderly patients, we went more towards the reverse shoulder arthroplasty. The only patient that we did a soft tissue repair were these were the patient with early to late chronic dislocation. And we assessed this patient using the standard prompts. And what we found is that comparing the three procedures in a soft tissue repair, Eden hyphenate did better. So they showed good to excellent outcomes, followed by latter J procedure, which had fair to good patient-reported outcomes, and the repair did the worst. They really had poor to fair outcomes on all patients that had a soft tissue repair. But there's a bit of bias there because the follow-up period was not the same, and the patient with the repair, they had a shorter follow-up. We also had one rib dislocation in all these cases, and we didn't have any redislocation in a latter J or Eden hyphenate. And this chart just shows the prompts as I've said them. You can see in general, looking at, we use the ROE SSV, and in general, Eden hyphenate and the latter J groups, they did fairly okay, but the soft tissue group did poorly. So this is just an example of a case of a gentleman who was dislocated for 4 weeks, and we took him in for a latter open reduction and latter J procedure. I think the important thing here is that what you must pay attention, and I've stopped doing this, especially when you have a soft head, is to put a facula in the joint. If you put that facula in the joint, then you will see post-operatively compressed on the head, on the inferior edge of the head, and that head just begin to collapse from there. So if they have a soft head, they've been out for too long, avoid putting the facula in the joint. Okay, but we went on to do a latter J for this gentleman, and routinely I repair the capsule when I do a latter J, and even in this chronically dislocated shoulders, you can find the capsule, you can release the capsule, and you can be able to repair it. And this way is controlled X-rays, and this was him at 1 month review. So managed to get him a fairly good range of motion with minimal pain. This is another patient with a chronic shoulder dislocation that was out for 2 years with a tuberostemal union, and this is what I'm talking about. So there's a case that we went through the greater tuberosity, did tuberosity osteotomy, accessed the joint through that, cleared the intraarticular fibrosis, and then achieved postless open reduction, did a latter J for him, and fixed back the tuberosity. He was far from the north side, so we only had 6 weeks, followed him out for 6 weeks, this gentleman. This is one of the patients from the soft tissue group that at the time of the surgery, we found her to be having massive rotator cuff tear involving the entire cuff, anterior cuff, superior cuff, and the posterior cuff. This was still early dislocation as well, the release of well, it was a bit late dislocation. So we opted to treat her conservatively. And you can see, we opted to treat her with an open reduction and soft tissue repair, repairing the rotator cuff. You can see at 6 months, her ranges of motion is not so good, and she's doing quite badly, and she still has quite a significant pain. Of note, you can also see that humeral head, although she did not have a frank dislocation, that humeral head remained slightly subluxed, which I'm not sure if really that correspond to her symptoms. So the reverse shoulder group, we assessed these patients using the constant score and the Oxford score. And this special on both scores, they did to excellent, all of them. But this tends to be a difficult group, because in this group, you have to pay attention to the clinoid bonus. Sure, if you can, these cases must all be planned before you go to theater, how you're going to position the clinoid component. Comparing this with the joint preservation surgery, this is probably the easier operation compared to the other two. It's easier in a sense that you can do in situ cut with the head still in a dislocated position. You take down the subscap in that dislocated position, and really don't have to worry about much, because from there, everything else is easy from there. But you have to address the clinoid bone loss. So this is a case that we had, and you can see how significant that bone loss is, almost more than 40% of clinoid bone loss. So how do you address that? If you look at the augment design, majority of the augments are meant for superior and posterior clinoid bone loss, not for anterior clinoid bone loss. So in all our cases, we've been treating them either with a bone graft or with just repositioning of the clinoid base plate. This case, we treated with a bone graft from the humeral head. The humeral head was a bit soft, so what we did is, you can see on that CT scan, that humeral head fits perfectly into that defect. So we left the cartilage on the humeral head just to get a screw patches, and from there, then we went on to continue with the reverse and avoid the screws from the bone block as we place the screws of the base plate. And we followed up this patient, and at 3 months, we did a PET CT, which showed that there was perfusion or a blood flow into that bone block that we put there. This was at 3 months. We had 12 months follow up on this gentleman at the time of the surgery, and we didn't go on to have any problems. This is a similar case that we treated differently, similar amount of bone loss. In this case, we just treated this patient with a reposition of the clinoid base plate to place it a bit superior and a bit more posterior. Then we aim for more inferior overhang, and you can see at 1 year, she has regained most of her function. So you can see these procedures actually do improve function in these patients, but these are not easy procedures to do. There's a lot of decision making to do in these cases. This is a recent case that we did this week. You can see this is a patient with a chronic dislocation, been out for 2 months, and the obvious thing there is as an anterior clinoid fracture. This is not a pseudoclinoid, it's an anterior clinoid fracture sitting more medially. And what we did, and I can see that fragment, we have reduced that fragment back, that clinoid fragment back just to fill up that defect, and fix that with a screw, and then went ahead to continue with the reverse shoulder replacement. So these procedures have a lot of complications. Was the same for us. We reported very high complications, but majority of the complications did not require reoperation. We had one patient that had a vascular injury at the time of the surgery. This was a patient in the reverse group, was not in a joint preservation group. The big problem in the joint preservation group was persistent subluxation, which did not seem to correlate with the outcomes in our patients. And then, of course, you're almost guaranteed that this patient is going to require, they're going to have osteoarthritis. So we had this one particular case that required osteoarthritis. This gentleman, he was dislocated for 5 years before we operated on him. We operated on him in 2018, and in 2021, he had persistent stiffness and poor function, and we took him back for removal of screws, arthroscopic osteocapsular release, and this managed to improve his function, and this was his function last year. Asked him to send me his pictures. He works as a hairdresser. He was unable to do his work before this. Although he has arthritis, you can see that the level of arthritis does not correspond with his functioning. So he was able to go back to his work, and he has not needed any surgery to this day. So, but also the reverse shoulder, these cases also had high complications, but none of the complications required a revision. All the cases in the reverse were treated with a 155 prosthesis, and none of the cases we managed to repair the subscapularis. And as a matter of fact, back then I was not repairing subscapularis when I was doing the reverse shoulder arthroplasty. So I was not none of them had a subscapularis repaired. And this, even though we didn't repair the subscapularis and was chronically dislocated shoulder, none of them had persistent instability or a pre-dislocation. So what we noted from the entire cohort of the patient is that there was a significant correlation between the length of dislocation and the probability of them developing complications. And 82% of the complications were really seen in the patient with what Goga called an ancient dislocation. So what we learned, and this is our decision making, this is how we make our decision now. So preoperatively, must always get a CT scan for this patient. Whether I should get an MRI or not, I'm not really sure, but maybe for a patient between the age of 40 and 60, it has to be a very difficult group to make a decision on whether you're going to do a joint preservation surgery or you're going to do a joint replacement. So maybe MRI may be able to help you there. But interpreting the MRI in a dislocated position is difficult. You really cannot tell much, but what you really want to know is the rotator cuff muscle bulk. Do you still have rotator cuff? The CT angio, this has been a topic, a hot topic recently in our meeting. This is the case that we did this week, and you can see we did a CT angio. Just trying to get a laser. We did a CT angio for this lady, and you can see the vessel is just sitting there. This is the head, that's the vessel there, is there. But this doesn't really change your management because we already know that vessel is there. So what do we want to know from a CT angio? What is the proximity of the humeral head to the vessel? I think number one. But maybe the important thing is there pseudoaneurysm or not? I have not seen any pseudoaneurysm in these cases. When I operate them, I've heard about it in the meetings, everyone asking about it, but I'm yet to see anyone with pseudoaneurysm. So I really don't know what is the value of the CT angio. Maybe these cases with a subclavicular dislocation where the humeral head is sitting medial to the coracoid process. And I'm saying this because this was a kind of a case where I had a vascular injury in. And I had another one similar, that where I had a near miss, almost injured, but I managed to get away with it. So maybe these are the cases that we should get a CT angio. But except for that, I really don't have an indication for CT. But from our lesson of these cases and looking at what already been described in the previous literatures is for us, patients younger than 40, we try to do joint preservation surgery, regardless of the duration of the dislocation. We stopped doing soft tissue repair alone. So if we do a joint preservation surgery, we'll add some form of bone loss. And what guides us on that form of bone loss is if they have an ancient dislocation, if they are epileptic, we'll do iliac crest autograft. So we'll then inhibit them. If they don't have that much bone loss and they don't have comorbidities, early to late dislocation, these are the cases that we do a latagen. Latagen is easier to do than iliac crest autograft in these cases because you take off the coracoid out of the way and all you need to do is to deal with the position of the humeral head. We think every single patient with a chronic shoulder dislocation, and that's how I've changed my practice, should be treated with a reverse shoulder arthroplasty. We've seen that they do better than all the other procedures. The difficult group is this group, 40 to 60. How should we be treating them? I'm still wary of the hematoplasty, and I've not been doing any hematoplasty for this. So if I have any reason why I think the joint preservation surgery won't work, I would rather do a reverse shoulder arthroplasty in this patient. This is not an easy procedure. This is a decision that you must involve the patient and they must understand that they probably may need a revision late at some point, and you're trying to keep them functioning now, but later on there might be nothing for you can do for them. So it's a decision that involves the patient, especially in this age group. So a lot is spoken about a skillful neglect. And I kept on asking myself, what is a skillful neglect? So I decided to ask our good friend ChatGPT, what is a skillful neglect? And he gave me a first definition. I was not happy with it and said, what is a skillful neglect in a patient care? This is the definition he gave me. And it says, skillful neglect means choosing not to intervene for the benefit of the patient, really, focusing on attention and resources for the well-being of the patient. And so this is a deliberate and a thoughtful process. So this is not just a patient that you see in the clinic, say chronic shoulder dislocation, we're not going to do anything for you, because we know surgery improves pain levels in these patients. We know that surgery improves function in these patients. but we also know surgery it can be dangerous in this patient, and they can have a very poor outcome and severe complications. But it's a matter of balancing between risk and benefit. And I think I agree with what ChatGPT said. So, and I have cases that I've treated with a skillful neglect. The 71-year-old male has been dislocated for 9 years. He has pain, but it's a pain that he can control with analgesia. And his function was not too bad. He's a pensioner. He's not doing anything. So in discussion with him, we opted to treat him conservatively. The 22-year-old came in as a police recruit sent to me because they picked up that there's something wrong with his shoulder when he was training for shooting. And we did a CT scan, and you can see there's nothing we can do for that clinoid in this young man. His clinical function is fairly okay. So we opted not to treat him with any surgery, and we left him alone. This is another patient, a 74-year-old. It's been dislocated for 5 years. If I ask you which shoulder is dislocated, you might struggle to tell me because she has a pseudoclinoid. She's been out like that. She's using this arm. She has pain. All she comes to us for, she comes to get a pain medication. And this is just some of the cases that we have. So decision making is quite important. You need to be aware that you can actually treat this patient. And if majority of them, to be honest, if you leave them on for long, they may not need surgery. But there's a lot of patients that don't tolerate being out for so long, and they don't tolerate the function they get with it in a dislocated position and the persistent pain and the cosmesis, and they want an operation. Another issue is, and we've seen these patients, the patients, when they fracture in that dislocated position, they fall and they fracture. It's difficult to deal with those fractures. So it's better to get them in a relocated position. I think I'll stop here. Thank you so much.
Thank you so much, my dear professor, for this very interesting talk. And we have just one question from Dr. Osman. Do you consider coracoid osteotomy to gain access?
So thanks, Sham. A good question. So not routinely. I a CT scan. If the patient needs a lateral J, it's obvious I have to do coracoid osteotomy. But if I'm not going to do a lateral J, I have not had a case that I needed to do a coracoid osteotomy. So I had one case for a reverse that I fractured the coracoid at the time of the reverse, trying to reduce this. And we just fixed the coracoid back. But I don't routinely do coracoid osteotomy to get access for reduction, unless I'm going to do a lateral J.
Yes. Thank you so much, sir, for your interesting presentation. And I think our next speaker will be Dr. Graf. Professor Bassem, please.
Yes, is it okay now with the sharing with Dr. Graf?
It's okay for you, sir, Dr. Graf?
Dr. Graf?
Yes, he's working.
Yes. Great. So may I present Dr. Graf? He will talk about shoulder replacement. What can we expect?
Thank you. Hopefully everybody can see or hear me at this stage now. I'm having a little problem with my Wi-Fi situation at my coastal residence. I did act as a consultant for Arthrex before, and for the purpose of this talk, I'm going to concentrate on the osteoarthritic shoulder with the intact cuff, and I'm not going to open the can of worms regarding fractures, sepsis, etc. This talk will be presented in a fairly narrative structure for time management, while grounding each storyline in a meticulous research data to ensure a balance of storytelling and empirical evidence without deep diving the specific articles. The power of the overstory has been highlighted by Malcolm Gladwell in his book, The Revenge of the Tipping Point. And the overstory is just a subject that can influence, it is regarding a subject that can influence your philosophy, decision on specific topics without realizing it. It slowly infiltrates your subconscious and influences your decision making. The overstory in simple terms is just, what is the flavor of the day? If I look back at my practice for the last 25 years, I can see that I've changed my ways quite dramatically. In the early 2000s, learning to do the reverses only about 10% of them, where currently I think only about 10% of my cases is the anatomic. And I cannot help to ask the question to myself, was it because of the reverse mania or changing of the overstory, or did I really change my ways based on data? At least for my own concern and realization, I know that there's a lot of been improvement on the old Grammont type of prosthesis regarding lateralization, cutting of the angle on the humerus, and preoperative planning. So there's been a lot of improvements regarding the old Grammont prosthesis. When we're discussing the question, the patient, the expectations, what we can expect, we must just realize that the most important party in this whole discussion is the patient, because they want to know if their pain going to be better, is their function going to improve, will they do their sport afterwards, will they need another one later in their life. And nowadays they ask me, Doc, are you going to do anatomic or are you going to do a reverse? They all use Dr. Google, and they know what is a reverse and what is an anatomic. And just remember, they expect perfection and permanence, sometimes from ruin, like the cases from Professor Rajuane. Dr. Charles van der Berg, a good friend of mine, has told me that happiness is that feeling you experience when you get more than you expected. But the flip side of the coin is that unhappiness happens when your expectations are not met. Therefore, I think we must base our decisions on data and not on the current overstory. Our decisions has a great direct influence on our patient's happiness. So we better keep it real. So regarding range of motions, and you compare reverses or anatomics, your patient will have more than adequate range of motion with either of these type of procedures. The difference can be on the reverses, you might lose a little bit of internal, external rotation level, which in average doesn't make a difference. But I take this in consideration when a patient has had a reverse on the contralateral side, and I have to make a decision on the other side. If the patient cannot reach behind him for personal care, I would err towards the anatomic on the other side to guarantee him reaching behind him, because that might be extremely important for the patient, although you feel maybe a reverse will be better. So considering functionality and pain, we know that all PROM squares and all outcome studies will surpass the minimal clinical important difference, and you'll have more than happiness in either of these procedures. It doesn't matter which score you're doing or what the PROM scores is. The patient will ask you, how long will my prosthesis last? And we know from the study that 80%, how long will the recovery take? And that 70% will reach a maximum range of motion by around about 1 year, but it can improve up to 1.5 years, and 80% will reach maximum clinical improvement by almost 1 year. And the question that's asked quite often where I practice is, Doctor, will I play golf again? And we know from the study that the golf returning will be about almost right about 93%. And this is an 80-year-old guy playing golf with a right-sided reverse total shoulder arthroplasty. Tennis has got a good return. The contact sports, there's a very low return of the sport. Doc, how long will my prosthesis last? In the pool registry, over all registers, we know that anatomics you will have a survival of anatomics about 92% in 10 years. Hemis about 90%. Reverses a little bit more, and about 94%. So thus, over 90% of your shoulder replacement will last more than 10 years, and patient benefits will be sustained. The problem is after 10 years, and the water starts getting murky for reverses, and even get much murkier after 15 years due to loss, range of motion and pain starting to creep into this. It's even murkier for males, and younger males, especially 10 years down the line after having a reverse total shoulder arthroplasty. We know from anatomics, due to high poly failure and cuff failures, you are lucky if you reach 10 years. Although we all have patients that can reach a little bit above that with anatomic reverses. So they will ask you, Doc, what type of prosthesis are you going to use? And if you want, the first question you have to answer is then for yourself and even for the patient is, can you do an anatomic or a reverse for a patient who's got osteoarthritis of intact cuff? We know that reverses seems to give less reoperations, less complications, maybe a little bit of superior pain and disability index according to the study, But there's no difference in prompts between reverses and anatomics. It seems that anatomics might give you a little bit of better external rotation. So my own anecdotal impression on the subject is that my best anatomic outperforms my best reverse by far. But on average, my reverses outperforms my anatomic shoulder replacements. So my own personal philosophy is to try and identify that sweet spot for the perfect patient, for the perfect anatomic. If you want to base your choice, whether you're going to do an anatomic or reverse, just on the incidence of revision rates, we know from the Australian register, there's no difference in 4-year cumulative percentage revision rate for either of them. Although there might be a little bit of higher revision rate in the first 3 months for men, and a higher revision rate for females after 3 months for anatomic total shoulders. The anatomics, the Australian joint register gives us a unique opportunity for shoulder arthroplasty research causes modeling for failure. There's some modifiable and non-modifiable risks. Some of them is under control of the surgeon, like the choice of implant, fixation, augments, and such. Your non-surgeon variabilities, which you have very little bit control about, is age, sex, BMI, and preoperative pathoanatomy. The one non-modifiable risk factor that you're faced when you make your choice between you're going to do anatomic or reverse, female sex, you must realize, has a higher significant higher revision rate for all shoulders, reverses, and anatomics. Preoperative anatomy, and this was quite a realization for myself because I didn't know this. I always thought that Welsh, according to the Welsh classification of preoperative glenoids, you'll have a higher revision rate for the B2 glenoids. And according to the Australian register, contrary to many surgeons believe, the B2 glenoids were not associated with increased revision rate. In fact, B2 glenoids had the lowest revision rate according to the register. So it seems like the Welsh classification doesn't play a big role on whether you're going to do a revision or not. Age, younger age, we know is associated with a higher revision rate. And under 55 years is your highest revision rate. And although this is a non-modifiable risk factor that you're faced of, many decisions you make can either compound this risk or you can try and lower the risk for the patient. And that is modifiable, meaning your choice, what implant you're going to use, what fixation you're going to use, the way you're going to do it, you can either make it better for the aging or the younger patient. We know that the effect of age with shoulder arthroplasty and anatomic cohort older patients have a higher risk of readmission and mortality than the reverse group. We know from Wagner that there's a 3% decrease in revisions with every 1 year increase in patient's age for all total shoulder replacements. In this study, looking at complications from the United States regarding surgical complications and revisions, they found there's a cutoff level of about 50 years. Below 50 years, there seems to be no difference. Above 50 years of age, complications in the total shoulders were higher than the reverses. And especially males seem to have a higher complication rate. My question out of this article is whether 50 years is that age where we start seeing cuff problems and might be the reason why patients in the age group differs and start having problems. You can do an anatomic and reverse shoulder arthroplasty for osteoarthritis and an outcome of 80 years and old. Both of them will give you a fair, good, same result. But I think the devil is in the detail. If you read carefully through the study, you'll see that the complications for the reverses might be controllable risks, and it's more treated conservatively. It's usually fractures or acromial stress fractures or notching, which you can manipulate with a better surgical technique, where the complications in this age group for the anatomics are more fatal. It's usually sepsis, dislocations, cuff tears, and usually ends up with surgery with a much worse result. Just as you think you can sort this out, these two studies will show you no significant difference in the revision rates for either anatomics or reverses for the 70 or 80 years old group. If we look at the New Zealand register, they will tell you that, yes, of course, when you're 40 to 50 years or younger, your lifelong revision rate will be higher because your lifespan gets shorter as you get older, your risk will be lower. But importantly, across all ages, revision of anatomics is higher than reverses. By sex, at all ages, females had higher revision rates than males regarding anatomics and reverse prosthesis. So the age issue is whether it depends where you say it's young, younger, or old. I think the important factor to remember here will be you are dealing with a patient, the younger they are, the higher the expectations. The higher the expectations, the narrower the gap of happiness gets. And if you don't tone down the expectations or you give them over expectations, you'll have an unhappy patient. But just as well, I cannot tell you to be a one-trick pony. You cannot offer for your younger guy anatomics, the older patient gets reverses, because you must adapt to what you are faced with and the risks that you are dealing with. Cuff failure is one of the bigger risk factors for failure of anatomics. And we know that cuff failure can be either acute, like this case of mine that had complete failure of the cuff within 2 years. We've had to revise to a reverse. But we know that cuff can also be a slow, progressive onset. Dysfunction can occur even if there's no tendon disruption due to fatty degeneration and cuff thinning. And advanced age has been linked to increased fatty infiltration. Disuse, or a so-called stiff shoulder preoperatively, is usually a bad case for anatomic because that cuff hasn't been functioning for quite a time. And should you do an anatomic, your risk of failure can be very high. We know from Butch Christian's presentation that early cuff failure can be gradual and it can be noticed within 2 years after procedure, as seen as elevation of the humeral head. But sometimes the indications is right in front of you, usually advanced age, limited range of motion preoperatively, general health like diabetes, CCF, rheumatoid, and fatty infiltrations. Walsh has told us that anatomic total shoulder only addresses the bony pathology, and it does not stop the cuff disease. So some of the modifiable risk factors under your control will be whether you're going to use a hemi, stemless, anatomic, or total shoulder, or a normal stem prosthesis. And often this can have a big influence on the outcome and the happiness and expectations of your patient. We know in the younger group, it seems like the stemless and the reverses gives you the same revision rate as compared to a stemmed and a hemi with a much higher revision rate in this age group. And for each and every specific age group, there's a difference regarding what prosthesis has been used. The all poly, which we know is the weak Achilles spot tendon of all anatomic total shoulders. Sperling has shown us there's a steep drop-off at 10 years with extensive failure of polys after this time. The metal backs is even doing worse, and all metal backs, modular or non-modular, has a much higher failure rate according to the Australian Joint Register. There's a new kit on the block that could maybe relieve us from this problem. It's the so-called hybrid prosthesis. And Sperling and from the Mayo Group, they are reporting fairly good results in a short term with very little failure, 0.6 of total anatomic sustained glenoid-related complications, the mean follow-up of about 4 years. And survivorship free of revision was almost 96% at 7 years. Also in another study, we don't see the deep Kaplan, according to the Kaplan-Meier survival, there's no steep drop-off. And even in Australian register, joint register, the hybrids are outperforming the all polys, that's of course all the metals and all other type of fixation techniques on the poly. So what about the augmented glenoid? Surprisingly, or to me not surprisingly, augmented glenoid components had a significantly higher revision rate for all type of anatomic total shoulders. The augmented glenoid increases revision rate for type A glenoids, and the augmented glenoid did not lower the revision rate for type B2 glenoids. So at this stage, as reflected in this joint register, on the green line, you'll see the all augmented polys has a high failure rate at this stage. Stemless prosthesis has many advantages. It reduces the perioperative fracture, less bleeding, easier revision, and better. And for me, the best advantage for stemless is the better anatomical reconstruction of the center of rotation and the head height. As been shown already in 2025 and 2005, that you can reconstruct the humeral head much easier and much better if you don't have a stem attached to that head. And that has been shown also in this review study. And the Australian Joint Registry is actually showing that the early failures for a medium to short to medium term for your stemless prosthesis is much lower than for the normal so-called stemmed prosthesis. We cannot extrapolate the results of the stemless anatomics to the stemless reverses. I don't think the jury is out on that as such. We must remember that we are dealing usually with older patients, and the forces and mechanics on the fixation proximally for the stemless reverses are much different, especially during internal and external rotation. There's big disturbing mechanical forces on that proximal fixation of this prosthesis. And for myself, I'm very hesitant to jump on this car at this stage. Considering the pyrocarbons, this is really gaining some momentum, especially with good results from the Australian Joint Register, where you use a hemi, because these pyrocarbons has a very low modulus of elasticity, very much related to bone, a very low friction coefficient, and even with other studies in a longer term, it's outperforming all hemis in the cases. And I think this is a serious consideration, especially for the younger patient, that you want to do a shoulder replacement. And I've done like 3 now in the last year. Early results, it's not, still too early for me to comment on my own experience regarding this pyrocarbon heads. Technology assistance doesn't seem to give any better outcome and doesn't lower risk at this stage, but it's still early time. But at this stage, according to the Australian Joint Register, all technologies, computer assisted navigation, is not lowering our revision rate at this stage. So in summary, and I'm basing this on data and not on an overstory, older patients do better with the reverses regarding complications and revisions. Well-selected older patients with a functional cuff, good preoperative range of motion, can do well with anatomics. Just keep searching for them. Hybrid glenoids has a good early trajectory regarding longevity and survival. Stemless anatomics seems to be the way to go at this stage. Metal back and augmented glenoids has a high revision rate, higher than any other glenoid prosthesis according to the Australian Register. If you want to go to the hemi, seriously consider the pyrocarbon head for longevity due to less glenoid erosion. So if well executed, all patients' expected requirements regarding range of motion and functionality will be met with a shoulder replacement. They will participate in the most non-contact sports at some level. Complications excluding patients with a total shoulder replacement will have a 90% prosthesis survival in 10 years. Maybe you will never satisfy all the expectations of all patients, and especially in the younger patient. And I'm convinced that in future, artificial intelligence and machine learning will maybe help us to select the right prosthesis for the right patient for their specific expectations, and will have less unhappy patients. Thank you so much, and I'm so sorry for the hiccup earlier.
Thank you so much, sir. Professor Basim, please.
Thank you, Gerhard. Very, very interesting presentation, really comprehensive. We can move to Mike. I am honored to present Mike Mulder. He is the treasurer of our society, and he will talk about management first-time dislocation. Mike.
Okay. Professor Ashab, Dr. Flieger, thank you very, very much for this opportunity to speak. I'm coming to you from the other end of the continent, down in Cape Town. Can you see my screen?
Yes, sir.
Okay. Let's do that and say that I've been given an enormous topic today to speak about the management of the first-time dislocation. And my disclosure is that I have no biases or financial incentives related to this topic, and that I'm only going to talk about anterior dislocations. I'm not going to discuss posterior or multidirectionals. And the other disclosure, which I haven't included, is that there's no way that I can give you a comprehensive explanation for what to do for every patient. But what I hope to do is to give you an overview and touch on some of the relevant issues. Why are we talking about this? And that is what we want to know is what to do when this happens on a Friday night in casualty centers across our continent and arrives at your office on a Monday morning. Well, the simple answer is it depends. It depends in Arabic, it depends in French, and it depends in the local South African language called Xhosa. It just depends. It depends on the age of the patient, the gender of the patient, the pathology that has happened as a result, whether the patient has features of hyperlaxity and any associated injuries, what the patient's lifestyle is, what the patient's sporting aspirations and activities are. It depends on the environment where you practice. It depends on, it's going to be different in my hospital. It's going to be different in Khartoum. It's going to be different in various parts of our continent. And it's going to depend a lot on the patient choice. It's going to depend on many things. And I'm going to try and highlight some of those things rather than giving you the exact answer. Why do we talk about this? Well, young dislocations, the concern and the issue we are trying to prevent is future dislocations. We know that each future dislocation brings with it more damage to the local structures, both the bone, the soft tissue, the nerve. It reduces the quality of life and the ability of that patient to perform his job and his sport. And we know that there are many, many factors that we're going to touch on. And so each patient in the environment is different and it requires a personalized approach. The incidence, we know that it's a very common pathology. We're all going to deal with it sometime in the next 2 weeks. We know that up to somewhere between 10 and 50 patients per 100,000. And we know that the prevalence is going to vary according to age and gender. We see two peaks of high incidence of dislocations, one in the young patient, usually male, and usually as a result of sports activities or the kind of things that young males get up to. And then the other high incidence is in the over 75 category, in this case related more to falls. One thing that has been shown initially by Leonard Havelius in his excellent natural history review of shoulder dislocations is that the older you get, the less likely that you are to dislocate again. And that's a fact that needs to hang in our minds when we approach patients of various ages. The older you are, the less likely future dislocations become. Not impossible, just the factors, the likelihood of a dislocation at another dislocation at 17 is very different to another dislocation at 37. Other factors, of course, modify the likelihood of this dislocation: gender, sports, hypermobility, and bone loss. But not everything gets better with age, unfortunately. Older patients are more prone to getting cuff tears, fractures, and neurological complications. So let's just talk about some of the factors or the issues that affect older patients. If we look at, this is the population pyramid of our continent. We see that we are a young continent compared to the Western and Northern and Eastern colleagues. In patients over the age of 40, we have to worry less about recurrence of dislocations, but more about the fractures and about the neurology and about the rotator cuff tear. So we'll start with these. We know that particularly the axillary nerve is commonly affected with anterior shoulder dislocations in somewhere between 30 and 60%. And this incidence of neurological injuries gets higher as the patient is older. It's affected by the violence of the dislocation, the duration between the dislocation and the reduction, and also, which is particularly important in our continent, the violence of the reduction. Archie spoke earlier about the sometimes variable access that our population has to primary care, and sometimes reductions can be the source of neurological injuries. We all look for the axillary nerve, but remember that the remainder of the brachial plexus can also be involved, particularly in older patients. But fortunately, most of these will recover by 12 weeks. Rotator cuff tears, these are also more an affliction of the older group over the age of 40. When we compare the rotator cuff tears, which occur in association with dislocations, we see that they more often involve the subscapularis tendon and infraspinatus tendon when compared to other traumatic tears. Being a traumatic tear, they perform better if you surgically repair them, but when compared to other traumatic tears, their outcomes are poorer. So when you see a patient who's sustained a rotator cuff tear as a consequence of a dislocation, do not, or you have to counsel that patient to perhaps have a lower expectation compared to the other traumatic tears we see. And then there's this terrible triad, which involves a dislocation, a rotator cuff tear, and an axillary nerve palsy. And I think the particularly bad version of that is when you have an acute extension of an old tear, where your ability to repair that tear is compromised. So that's a really difficult situation in the elderly. Well, the question always comes up, do you have to address the labrum if you're repairing a traumatic rotator cuff tear which has occurred as a result of a dislocation? Well, in older patients, the answer is no. The evidence, the research shows that you do not have to repair the labrum when you are repairing the rotator cuff, but in younger patients, now I use that word broadly, but generally under the age of 40, if you have a rotator cuff tear and a labral tear, you need to repair both, but be prepared to deal with increasing stiffness as a result of that. Fractures, we know that these are common, particularly in the older patients, 65 and above. And here we need to treat those fractures on merit, performing reductions or replacements as the fracture dictates. So in summary, for the older patient, meticulous exam, look out for that axillary nerve. In our practice, an ultrasound is freely available in many surgeons' offices, and it's a cheap way of performing an assessment of the rotator cuff. I use a sling for comfort for about 2 to 3 weeks, early mobilization, but I would have a low threshold to perform an investigation such as an MRI if the patient is not recovering their range of movement. Now, let's get more to the point and talk about that young dislocator. The young patient, usually male, usually as a result of a work-related injury or sports injury. They have high demands, both in terms of their desire to return to sport and work, and they have the highest risk of future instability. Now, I mentioned earlier that the older a patient becomes, the less we have to worry, but the young patients have a 13 times higher rate of dislocation than the older patients. And this is particularly in the teenage boys. Now, just one note on we know most of the research is dedicated to the young teenage male, but there is some bias simply because we see a lower incidence of teenage girls experiencing dislocations. But the profile activity of young women is changing. We're seeing increased participation in formerly male sports. And so we must be careful, or we must evaluate whether we apply the same rules to a young woman athlete as what we do to our young men athletes. Another independent factor that will increase the risk of your patient's future dislocation is overhead work or sport. Now, in South Africa, we have this religion called rugby. It is a violent collision type sport, and it dictates to us how we treat the patients who are involved in that sport. But we have to recognize that other sports also involve violence, particularly soccer goalkeepers, surfers, kite surfers, and people who put their lives on the line working on high scaffolding. We know that it's not just the loss of physical barrier to dislocation, but also the loss of neuromuscular coordination. And the patient's future desire to partake in a sport and their current lifestyle and occupation is going to have a bearing on the choice of surgery that we perform. This is a truly essential part of our assessment and evaluation of our patients is hypermobility. It is a significant independent risk factor for future instability. It raises the risk of dislocation more than 2.5 times at every time frame. So if your patient has a patient with no hypermobility has a 2.5 times less dislocation risk than a patient with hypermobility. And it is important in terms of your decision making for treatment, your decision making for surgery, your decision to operate or not, and it has a significant impact on failures of our surgery and how we rehabilitate these patients. So it is truly essential to make a concerted analysis of the patient's degree of hypermobility. Now, the pathology that is involved, or the evaluation of the pathology from your first dislocation, must include the soft tissues, the capsule, the labrum, the ligamentous structures, as well as the bony architecture. And again, here's where local variation is different. In my environment, every investigation that I do costs my patient money, and I have to recognize that I must be able to justify every additional test that I request. So a basic set of x-rays, particularly an AP, a lateral view, combined with an axillary or a Valpo or a Bernageau view, gives me an essential baseline of information. And I have to be able to justify my decision to spend my patient's money on a CT scan or MRI scan. And we'll talk about that when we're going to employ those, when those modalities are important. Obviously, every surgeon is going to have different abilities. I know my Egyptian colleagues have easier access to MRI scanning than what we do. The capsule and labral pathology, we know that with a first dislocation, with one dislocation, almost 90% of patients, irrespective of their age, will have a Bankart tear. That is a detachment of the glenoid labrum off the bony surface. With a subluxation, we have a roughly 77% chance of a Bankart tear. So although it might not be the dramatic dislocation, the subluxation can be equally problematic. An ELPSA, anterior labral periosteal sleeve. This is the injury where, in addition to the Bankart detachment, you also have the periosteal stripping is involved in higher energy injuries, particularly what we see with our rugby players. And as I mentioned earlier, it's not only the loss of physical restraint, it's also the loss of proprioception that affects these patients' stability. Bone defects get a lot of attention, and necessarily so. And down here in Cape Town, Dr. Joe De Beer, along with Steve Burkhardt from America, and more recently, Dr. Yamamoto from Japan, have highlighted the fact that we cannot look only at the glenoid or the humeral head. We have to look at both in conjunction. Joe De Beer spoke about the engaging heel sacs, and Dr. Yamamoto with the glenoid tracking. And these, once again, are predictors of instability. They affect the patient's risk of stability. They affect our choice of surgery. We talk about the significant bone loss where arthroscopic procedures are possibly ill-advised. And remember that the amount of bone we're talking about is tiny. We're talking about a 4 to 5 millimeter bone loss is enough to create a failure of an arthroscopic procedure. And this is the situation where bone loss is in question, CT scans are essential. So let's get down to what we really have to talk about. What do we do? And it boils down to this. Are we going to operate on that 19-year-old who dislocated over the weekend, or are we going to leave them alone? Well, let's go with the easy. Once again, I'm leaving the hardest part of my talk to last, trying to build a suspense on a Friday evening. Who not to operate on? Well, over the age of 40 years, particularly in a low demand patient who has no associated bone loss, no cuff repair, that patient can successfully be treated without surgery. We know that the greater tuberosity fractures, whether in young patients or in old, also correlate with a low future dislocation risk. So these are the patients, these are the easy patients who I can agree to leave alone. Now, in the younger patient, under 30 years, often male, high demand, we are really fortunate in 2025 to have an abundance of information to help us make this decision. We have randomized controlled trials, meta-analyses of various trials. We've got research which has come from 4 continents over multiple year periods, and all of it points very clearly to one thing, that an arthroscopic or open Bankart repair can reduce significantly the risk of dislocation and symptomatic instability in a young patient. It will aid that patient in getting back to work or sport earlier and prevent them losing time from work or sport in the future. And by preventing future dislocation, it prevents more complex pathology from occurring with subsequent dislocations, such as fractures, nerve injuries, or bone loss requiring more complicated surgery. And this is just one quote saying that arthroscopic Bankart resulted in a 7 times lower rate of recurrence. So almost certainly in a case of a young patient who is high demand, surgery is the better option in terms of preserving their quality of life and day-to-day tasks. But when? Well, we know that from several papers showing comparing the results when a Bankart repair is performed within 4 to 6 weeks of the dislocation versus those where the surgery is performed later than that, that as soon as possible, earlier is better. But we do not see patients in a perfect world. We see them when they have commitments of sport, school, work, family, children's activities. So we have to take that into account as soon as is feasible for your patient. It does not mean that you must tell the patient to lose his job in order to have the surgery or miss his school exams, but earlier is better. Many patients, particularly in my practice, come to me saying, well, what, doctor, can I finish the season? Can I do it in the school holidays or at the end of the season? I might get a contract for a club. Well, if they do it, if an athlete under 20 sustains a dislocation during the season, they stand a 40% chance of having another dislocation event, but they have a 90% chance of finishing the season. So what we have to do really is to balance the risks of doing the surgery now versus them leaving it and potentially having another dislocation, which means they are no longer a candidate for an arthroscopic Bankart. So that patient might have a second dislocation, sustained bone loss, which means that you can no longer do a Bankart procedure. How? Well, the take-home message from a number of papers comparing open versus arthroscopic Bankarts is whatever you do to do it well, that is what you must do. If it is arthroscopic, do that. If it is open, there's no difference. But do a well-performed Bankart repair to repair the labrum as well as the capsule onto the glenoid surface. That can reduce the risk of future dislocations. Of course, the Bankart has limitations. It has a higher failure in cases of bone loss, in cases of contact athletes, particularly our South African rugby players, in cases of epilepsy or seizure disorders, and we have to exercise caution in that hyperlaxity patient. And this is the case where if there's doubt about the ability of the Bankart to perform, where MRI scanning and CT scanning for clarification of the amount of bone loss can be beneficial. We know that the bone loss has, through a number of papers, been classified into more or less, of course, every paper has a slightly different number, less than 10%, more than 20% being significant bone loss, and then somewhere in between. But also looking at Yamamoto's concept of an off-track lesion, where the combination of the Hill-Sachs and the glenoid bone loss is something which would correlate with a failure of an arthroscopic procedure. In the case where we have bone loss, which is going to make an arthroscopic procedure less likely to succeed, we can add a remplissage, that is where we tuck the infraspinatus tendon into the glenoid defect, or, which is a South African favorite, is to perform a Latarjet procedure or an Eden-Himenet procedure with a insertion of a iliac crest bone graft. Pascal Boileau from Nice has given us some guidance on this with the injury severity score, giving us a scoring allocated to a number of features. And when more than 6 points is present, it indicates that we are likely to have a failure of an arthroscopic procedure. So let's just take an example. If I have a 17-year-old football goalkeeper, he's an adolescent. He's got a goalkeeper, so he gets 2 points, and he's got a Hill-Sachs. Now, that's not even including if he has any degree of hyperlaxity. So it does not take a lot before we start reaching what is essentially the limit of the capability of an arthroscopic Bankart procedure. So in the South African context, we perform a higher percentage of Latarjet procedures because a number of our patients are young and are involved in contact sports. But we need, this only serves to indicate that you need to question whether an arthroscopic procedure is the way to go. Now, another disclosure is that no algorithm can perfectly sum up all the factors that you have to take into account. But here's a broad Friday night take home. If there is no bone loss and you do not have a contact athlete, an arthroscopic Bankart is a perfectly acceptable and in fact recommended way to treat a first-time dislocator. If there is some degree of bone loss, either visible on the X-ray or on a CT scan, but it's minimal, then a Bankart procedure in a low demand individual can work. Maybe if he's a slightly higher demand with an overhead work or he plays sport, an open Bankart might be a more reliable way to go. In the middle ground, you have your choice. In South Africa, you'd most likely get a Latarjet, but a Bankart plus a remplissage, that tying down of the infraspinatus, is the way to go. Where you have more than 5 millimeters of bone loss, yes, you could go the Bankart and remplissage in a low demand individual, but you're more reliably treated with a bone reinforcement procedure such as the Latarjet or the Himenet. If, according to Yamamoto's classification of off-track lesions, you have significant bone loss in a high-risk individual, don't make the mistake that so many people do of going with a procedure which has a high failure rate. Rather go with the Bankart, with the Latarjet or even Himenet. Now, I started this off saying that it depends, and I'm going to come back to that, saying that the management of a first-time dislocation depends on many, many factors: age, gender, laxity, sport, your local factors, what you do in your practice. But patient choice is an important component, which we haven't yet spoken about. This is a decision which you make in many cases in conjunction with a family. You sit with the mother and the father and the 17-year-old athlete, and you talk about the risks of the various procedures, the risks of surgical versus non-surgical treatment, and give them the information to allow them to help be part of the decision. And these two articles really sum up that sentiment. They say that although we know all the variables now, it remains a personal decision made in between families, patients, and the surgeon. So my summary is that I'm going to sit on the fence. I'm not going to commit to what you should do for a first-time dislocation. I'm going to say that what would I do for my 17 or 19-year-old, having their best interests, both of their risks of surgery, but also their risks of sport and activities at heart. Thank you very much for your time.
Thank you so much, Professor Mulder, for this interesting presentation. Professor Bassem, you have any comments, sir?
Yes, I want to thank all the participants from South Africa. It was really a very, very rich presentations, and we enjoyed it very much. So I want to thank every one of you, and we hope to see you again here with other webinars. And thank you also, Dr. Al-Ashraf, which you made this possible. Thank you.
Thank you so much, sir. Many thanks to our dear guest speakers from South Africa. It was an honor for all of us. Thank you so much for being with us. And many, many thanks to my dear professor, Professor Bassem Fliga, for his great help in arranging this session of the webinar. And now we move to the next session, which is the elbow, wrist, and hand. And many thanks to our guest speakers from Egypt, from UK, and from Germany in the wrist and hand session. And I would like to thank my dear Professor Ashraf Abdelaziz for his great help in arranging this part of the webinar. And Professor Ashraf, let me introduce to you, Professor Ashraf Abdelaziz is a professor of orthopedic surgery and wrist and hand surgery in Al Azhar University. And he's the moderator of this part of this session. And please let me welcome my dear Professor Yasser Safuri, Professor of Orthopedic Surgery and the previous and the ex-president of the ex-head of the Cairo University Orthopedic Department. Thank you so much for being with us, sir. And I will let Professor Ashraf to moderate this session. Please, sir.
Thanks, our Professor Al-Ashraf, for this kind day. And now with our eminent Professor Yasser Safuri for his presentation about obstetric brachial plexus injury, treatment strategy, long-term result, and prognosis.
Thank you very much, Dr. Ashraf. Thank you very much, Dr. Muhammad Ashab, for letting me join your meeting. I'm going to talk about a very interesting topic, which has, for the last few years, been changed as regards the strategy, and a lot of new techniques were added. That's why I'm trying to put my experience in the last 20 years in this talk. All of us know that the mechanism of obstetric brachial plexus is a traction injury, pulling of the child when he is born, and this may be because of the large size of the baby or in the breech presentation. At the end, you can be the first one to see the patient referred to you from the pediatrician with the early Erb's palsy, as you see in the slide above. Then you should have the ability to diagnose and decide when to do surgery. Or you can face by the problem of having the patient coming to you in an older age, 3 to 4 years old, and you should examine the patient properly and see how can you help him. This will be my topic: how to put indications for surgery, how to look for the patient and to tell the patient for the prognosis, and special small techniques for your surgery. It was described long ago, but in the last few years, not last few years for you, but for me, maybe in the late 90s, then the development of microsurgery and the development of the fine sutures and the fibrin glue and the very high advancement of microsurgery and the microscopes, this made us more, for us, it became more easy to do the surgery. And I remember my professor, my mentor, Dr. Hadidi, when we did the first case, he just wanted to see the pathology. You wanted to see a patient 3 months old. What was the pathology? Is it really a rupture of the nerves, or it was like a compression? So it was very difficult for the anesthesia team also to do the surgery for a patient 3 months old. These were a lot of challenges and the beginning of using of nerve simulators, all this collected together, and then now I think it's for most of the centers, it's a very well organized and teamwork surgery, which is done on almost all the universities in Egypt now. So to classify, it's not a classification, as you all know. Herb's palsy means 356 injury. Then it is intermediate, 5, 6 to 7, total type, or it's only the hand and scapular paralysis. We teach our residents, is it an upper, extended upper, lower, or total? Very simple as this. The anatomy is complex and there are different approaches, but most of us use the supraclavicular approach, and in cases of total and extended upper, we use more generous incisions and we go with the posterior line of the sternomastoid, then we have our angle. So it's like a generous approach, more than the supraclavicular transverse approach in selected cases. But what I want to say here is that the anatomy is not the same in all the patients. And sometimes the carotid sheath is very close to you when you do the dissection. And bleeding is not accepted. You should be very meticulous because the baby is only 3 months old. And at the same time, the anesthesia team should be attending the theater, not leaving the theater even for a second. But what happens to a patient with an obstetric brachial plexus? There are different scenarios. Most of them recover. It's a mild traction, and that's what I see these days. In our days, these 5 years ago, then the rate of obstetric brachials, at least in my practice, have decreased a little bit because there are better indications for cesarean sections, and there is less possibilities of Erb's palsy. However, most of them recover if there is a traction injury. Some of them are left without any surgery, and they come from different areas in Egypt, neglected cases, and they have deformities and contractions, and then you can deal with these patients as secondary procedures. This is not my topic today. My topic is the indication of surgery and when to do surgery and your strategy during the surgery. Sometimes there are partial recovery and the patient has good shoulder or hand, but he has limited overhead elevation or elbow flexion. Then these are secondary procedures which can be done later on, not in the first 3 months of his age. The role of physiotherapy is very important, and you should have your team of physiotherapy. And these are the people who see your patients for a longer period of time, and they tell you the results. They are the team which is responsible for the scoring system, not the surgeon. Preoperatively, there are certain points. Sometimes the patient was in an incubator, so there may be a phrenic nerve traction injury. That's why you should do a plain X-ray to detect any insult in the phrenic nerve. Also, sometimes the patient is referred to you as obstetric brachial plexus, but he has arthrogryposis, very simply as this, or CP. So your diagnosis is very important as a surgeon. Does it happen both sides? There is an incidence for both sides. I did not meet it in my practice. That's why for medical legal issues, we do an EMG and nerve conduction studies. Plain X-ray is very important. CT myelogram in some cases, or an MRI in very rare cases. The types of surgeries, the most common is doing nerve grafts, exploration and microsurgery and nerve grafts. But is there a possibility for nerve repair? Not in my practice. Neurotization, there are two teams. Some teams, and there are some in universities in Cairo, like in Asyut University, they go with neurotizations early, even if there's a possibility of reconstruction. And they have very good results and they have published their work. But for me, I do not do neurotization except in avulsion injuries, or sometimes, and I will mention it later, if there is a delay in the recovery of the shoulder, but he has good elbow function, then I can do a nerve transfer earlier at 9 months or 1.5 years, according to his progress as shoulder function. But he regained his elbow function. I will mention it later on as the strategy of my reconstruction. Neurolysis, for my practice, I did not find that only neurolysis is possible to treat these types of traction injuries. Your microsurgery, nerve repair, and nerve grafts reconstruction is not like a vessel that you just want to have both ends exactly at the same edge, but it's very important to have them aligned and in proper nerve topography and without any tension, and give them a possibility of regeneration and blood supply in a good vascular bed. These are the golden rules for nerve grafting. And you allow them to sprout. So a nerve, when it is injured, the nerve fibers want to reach the other end. Just give them the space, give them the proper direction, then they will go and pass to reach the other end. Then there's like myelin sheath and regeneration of the nerve. Just put it in the same in the proper direction, then it will regenerate. The anatomy is complex, but all of us know that there are roots, C5-6, C7, T1, C8, T1, and then they form the roots, trunks, divisions, and cores and peripheral nerves. This is not a problem for anyone as a surgeon. But this is a puzzling slide, the topography, which is very important. And you should have like a book in front of you while you're doing the surgeries to see the different areas of the nerve inside. But I summarized this relation between the muscle, the peripheral nerve, and the root to my resonance in a very simple slide, which I will show you. As you see here, you should understand that a muscle, like a deltoid muscle, is supplied by a peripheral nerve, which is the axillary nerve. But this axillary nerve has roots coming from different areas, maybe not only from the C5-6, but from the C7 also. If you want to make the idea more clear, from this slide, if you injure the upper trunk, then you have lost some nerves, some roots, some nerves, some muscles. So if the upper trunk is injured, you have lost the suprascapular nerve, but you have not lost the upper trunk. You have lost the suprascapular nerve at the musculocutaneous, but the other fibers coming from different areas like C7 passing and continuing to join and form the medial nerve. But although there is injury of the upper trunk, there is some insult to the continuation of the posterior cord, like some of the muscles as the excessor capillarius longus, which is part of the radial nerve. So when you're doing your reconstruction, you should target the topography so you will have regeneration to a specific nerve, peripheral nerve to a specific muscle. This is the idea. Our reconstruction, as I said, I do generous incisions so that I feel comfortable by doing my coagulation and putting my setup for microsurgery. And I do as much as possible of nerve grafts, shoulder nerve grafts from both legs and try to construct everything. We use fibrin glue, and also in some cases, we can do a clavicle osteotomy. It's no problem to do an osteotomy in children. It will unite quickly and it will give you a better view if you just want to go more distal. Our strategy in these cases that I do nerve graft to every part of the brachial plexus, including the suprascapular nerve. I do not do spinal accessory to the suprascapular nerve when I do my reconstruction. I leave it as a backup plan because later on, maybe I use the lower trapezius for my transfer. And you have very good results of regeneration and good function of the shoulder by this strategy. Neuroticisation, as I said, on nerve transfers, there is some papers about the use of intercostal nerves, spinal accessory contralateral C7. In my experience, I use, in some cases, as I told you, of delay recovery of the shoulder due to the spinal accessory nerve to suprascapular nerve. The nerve transfers or nerve neutralization, for me, I leave it if there is root avulsion or if the relate presentation, I want to reconstruct the elbow by oberlin or the shoulder by spinal accessory to suprascapular nerve. Any patient presenting to us, better as early as possible to do the surgery. Best surgery for me is at 3 to 6 months. When to do the surgery, you examine the patient by yourself and you teach the surrounding team and maybe the physiotherapy. If you have a patient with brachial plexus with no biceps at 3 months, this is an indication. Or if it's a complete global type, or if it's loss of the hand function. These are absolute indications for a microsurgery. If you are in doubt, then you can postpone a little bit and observe the patient. If you are more in doubt, then you can do a CT myelogram, but the golden period is from 3 to 6 months. Never lose this period. So this is an example of the patient with Erb's palsy, has no elbow flexion and shoulder, and this is known as the policeman tip deformity. This is an indication of microsurgery. This is another case with the Horner's syndrome and loss of hand function. This is another indication for pure indication for microsurgery and brachial plexus reconstruction. If the patient has good shoulder and good elbow function, we observe and begin a type of physiotherapy in the form of exercises, no electric stimulation, and we encourage the movements by certain reflexes. So if the patient like this has improved in his function and his elbow improved as flexion, but he has no shoulder function, then this is a decision whether to wait for the improvement of the shoulder function and later on at 2 years or so you can do a tendon transfer for overhead elevation, or you can go for microsurgery and open early by a straight transverse incision and do a spinal accessory to suprascapular nerve. This is your decision. For me, if I found that the shoulder is weak and is not progressing much as the shoulder, as the elbow, I'll go quickly for the nerve transfer. If it's improving but not so, it has some tone in the deltoid and it has some movements which is reaching almost 90 degrees, then I can leave him and later on I can do a tendon transfer at 2 to 3 years in his age. During this period, I follow up the patient, I do physiotherapy to control any contractures and to stimulate the other muscles so that they are strong and I can use them later on either for the latissimus if there is like overhead elevation deficit, or if there is a core contracture, then I use also the teres major with the latissimus, or if the patient has the problem only of external rotation, then in these cases we can do a lower trapezius transfer. These are the cases in which we had the opportunity to follow up and we prevented any contractions. But if there are contractions, then we can do arthroscopic release of the subscapularis or the glenohumeral ligaments, and then we do on the spot a lower trapezius transfer. But I will mention this in another presentation. This is a test which was done in which you just cover the eyes of the child. He will try to move his hand to remove the cover, and then you can decide this spot, can he do flexion of the elbow, or he has loss of flexion of the elbow and the shoulder, and he needs surgery. I'll present some of the cases. They are not complicated cases, but just to simulate you that microsurgery is the golden standard to do to treat patients with Erb's palsy if they are diagnosed early. If they are diagnosed late, then there's a big problem, and it's a very tough situation for the surgeon, especially when they see the good results of microsurgery. These are the patients which were followed up by my team of physiotherapy, and all the patients were done at 3 to 6 months age, and also they included their follow-up with the secondary surgeries. And we always say that we take care of the patient until he begins to play sports, and this is about to 12 to 14 years old, and our results can extend until we reach this age. We can say that 84% of our have developed a very strong biceps and supraspinatus, and good shoulder function, triceps and hand function, which is allows the patient to do possible sports like swimming. This is an example of C5-6 or extended upper. It has no elbow or shoulder, and this is the early results in which the patient can do flexion of the elbow and better shoulder function. And we follow up this patient with our physiotherapy team. Even if he's coming from outside Cairo, then he can come at least 1 month, and we do like a video conference with the physiotherapy team until they are satisfied with the protocol and they feel comfortable. We do not do any electric stimulations. We depend mainly on the reflexes. This is the patient. Unfortunately, he was subjected to physiotherapy in his early age, and there was a dislocation of the shoulder. This patient presented to me 4 months in his age, and we had to do a microsurgery and also open reduction of the shoulder. This was a tough surgery. As you see here, this is an incision of the brachial plexus, and under the axilla, this is the incision to do an open reduction of the shoulder. This patient improved and he had good elbow and shoulder function. I will present other cases in which we had the opportunity to follow them for a longer period of time. This is a patient also with the extended upper brachial plexus, in which we did. This is the pathology, in which is the rupture of the C5-6, the rupture of the brachial plexus with good 5-6 roots, in which we can do our reconstruction, and a part of the C7 also. We did our grafts from these to the target, reconstructing on all the upper and middle and lower trunks. The middle one we construct also to give more of the plexus, which happens around the shoulder, because later on we can use some of the tendon transfers. We can reconstruct all what we can do with much grafts as we can do as a first stage. This is the picture. As you see there, the phrenic nerve, we do not touch the phrenic nerve. We do our reconstruction with as much as possible of shoulder grafts on both legs with our fibrin glue. This is the patient. She improved, but at 3 years old, she did not have this overhead elevation. We do not stop. We continue following up the patient, and we try to help him so that we can reach the age of sports, and at which we just finish our follow-up. And this is our last follow-up of the patients. This patient, we wanted her to swim and have an activity, a sport activity. So we had to do a muscle transfer. This patient, it was enough to use the latissimus dorsi. We take it and we transfer it through a transaxillary approach, diagonal on rotator cuff, with a special type of physiotherapy protocol, and the patient improved and had a very good overhead elevation, and she was able to go to swimming. This is another patient with the extended type, but he had also part of the C8, in which we did, as you see here, this is the incision, extended incision, journalist incision, and we did our microsurgery grafting. This is her early result of flexion of the elbow. We follow up the patient. She improved by time with a special protocol of physiotherapy. We do not use our patients much, but we have like a certain protocol of physiotherapy, and we always attach to the physiotherapy team in other areas other than Cairo, so that it can do strictly the protocol which we want. This patient improved. Then we had this follow-up. She had better overhead elevation, better hand function, but some limitation of extension of some of her fingers, and that she improved, and she was able at this age to stop physiotherapy and do some sports. As I said, there's always a role of secondary surgery that you never stop. You want the patient to gain the best function as you can. So in some cases, like this case, in which this is the incision of the brachial plexus reconstruction, she had good improvement, but she had no elbow flexion. In these cases, we do an EMG and we detect if there's some motor units in the biceps, and we have good flexor carpi and nares as clinical and EMG. Then we can think of nerve transfer, the Oberlin technique, in which we take part of the ulnar nerve going to the flexor carpi and nares and transfer it directly to the branch going to the biceps. And this is the recovery of the patient with better biceps and the patient improved as function and reaching more to her head and her daily activities, dressing by herself, almost all functions she is doing. At last, we do not want to reach this scenario of neglected cases. This patient was neglected with no microsurgery and ended up with a useless upper limb. Very disappointing. We wish this will not happen. Also, in these patients, you always should look at the hand. If this was not reconstructed earlier at 3 to 6 months, then it is a useless hand. We never want to reach this situation. Thank you very much.
Thank you, our Professor Yasser Al-Batrawi, Yasser Al-Safuri, for this nice presentation. If there is any question, we can send through questions. The next speaker, Professor Ahmed Naim, and he will talk about flexor tendon injuries. Professor Ahmed Naim.
Assalamu alaikum. Good evening, everybody. I'd like to thank Dr. Al-Ashhab for his kind invitation and for this very elegant webinar, and for allowing me to share with all of these great presenters and professors this specialty day of the upper limb.
It's an honor for us, sir.
Thank you very much. Thank you, Dr. Ashraf Abdulaziz, for your kind efforts and kind invitation. I don't know if do you see my presentation or not yet?
Yes. Okay.
Okay, we will talk about the repair of flexor tendons. Maybe the first who advocated repair of the flexor tendons is Avicenna, the known Muslim scholars in the 11th century. And this is a very challenging problem in hand surgery because many factors. One thing is that there is intricate and complicated anatomy, and we have to go inside this very closed space and trying to preserve as much as we can of the anatomy. And in addition, the nutrition of the tendon is at risk from the injury or from our surgical intervention. And keeping the nutrition is very important for rapid healing, decreasing the adhesions, and the restoration of the gliding. We have also to know that there's watershed area under the A2 poly and A4 polys for both the flexor superficialis and profundus tendons. And usually the tendons, the circulation or the nutrition comes more in the back on the dorsal surface of the tendons. In addition, one of the most challenging parts of the healing of these tendons that it starts with fibrin-loaded edema, and this will end with a scar tissue. And unfortunately, the scar tissue is not restricted to the flexor tendons alone. It leads to a zone of injury or a zone of scarring, hindering the motion of the tendons. It's the whole area or a very large area is spot welded, like this in the picture. And the solution is to start motion as early as possible. This is the only way we have to fight these scars. But knowing that the tensile stresses on the repair tendon, these are that stresses in grams regarding the activity. And if we want to overcome these stresses, we have to perform a repair which can withstand all these stresses. So this comes the proverb, the Egyptian proverb. Okay, اطبخ يا جارية بقى كلف يا سيدي. Let's have a look on the strength of the tensile strength of the most known core suture. Using 2-strand sutures only at the repair site, it will be at 2,500 grams. However, this will decrease by 50% and 33% by 3 weeks. So it will be unable to withstand light grip. This will improve the I'm sorry
احمد بيه هو disconnected يا فندم سعادتك. ممكن سعادتك تري شير تاني؟
أنا آسف.
لا العفو يا فندم. دكتور احمد عنده تكنيكال بروبلم. حضرتك ممكن تتصل بيا دكتور اشرف بيه بعد اذن سعادتك؟
حاضر بيه. بنحاول الوصول للبروفيسور أحمد. تقريبا عنده تكنيكال بروبلم لأنه فاصل خالص.
طب سعادتك ممكن حد من الزملاء يبدا يا فندم على ما الدكتور احمد يريجوين تاني يا فندم بعد اذن سعادتك.
تمام. دكتور حسام.
Thanks, Dr. Muhammad. Thanks, Dr. Ashraf, for the kind invitation.
I will introduce my dear friend, Professor Hussam Abu Dunya from UK, and he from Kafr Dawar also. He will talk about under side wrist pain.
Yeah, can I check that you are seeing my screen then?
Yes, sir.
Okay, good. So I'm Hussam Abu Dunya. I'm a hand surgeon based in UK currently, and we're talking today about a common problem we see, which is the undersided wrist pain. It's been always told that this part.
أنا آسف يا فندم دكتور
أحمد's back. Yeah, he's back.
أنا هستأذن حضرتك هنخلص البرزنتيشن دي وسعادتك تبقى ورانا على طول يا فندم. أنا آسف.
Well, I stop sharing. No worries.
Okay.
I'm so sorry for this disturbance. I changed the Wi-Fi. I have a problem in the Wi-Fi. I changed it. Okay. So in order to move, we have to increase the strength of our repair to withstand the normal or the light grip and strong grip and so on. And this what could be attained by the 4-strand and 6-strand configuration. So this is a hand surgeon. He is very confused because overprotection will lead to adhesions in the flexor in the repair of the tendons, and on the other side, over motion will lead to possible ruptures, and both of them has a disastrous consequences on the outcome. Let's start our story The story will start with cutting the tendon either in flexion while the fingers are extended or flexed. This will dictate the position of the distal stump. If it's cut in extension, the distal stump will be at the wound side. But if it is cut in flexion like figure B, the distal stump will be very distal when we extend the fingers. And both of them, the proximal stump can migrate proximally. To which extent there is a stopper here, like this man. Our stopper in reality is these thin muscles, what we call the lumbrical muscles, because they are attached to the flexor tendons, to the flexor profundus, so they can keep the flexor tendons up to the palm, not proximal than this. And we sometimes we be lucky if the vincula, this is the blood supply, the fold, the mesothelial fold, which transmits blood supply to the tendons, if it's not cut, can maintain and is strong enough to maintain the tendon in place. We know the 5 zones of injury of the tendons. And what about timing? Usually it's urgent, not emergent, unless we have a vascular insult. We have to keep in mind that the tendon deterioration occurs maybe after several weeks. After 6 weeks, mostly they will be shortening, so they will be myostatic contraction or deterioration. If there is questionable of infection, we can delay several days without a large problem. Usually, if we delay it to 72 hours, it will have no much problems. In order to extend our incisions, we can extend it whatever we like, but the tips here is not to cross the crease longitudinally. The flexion creases in the hand should be not crossed vertically. Otherwise, you can use whatever you want. Try to make flaps in order to widen your field and your visualization. You can retrieve your tendon by many methods. Maybe the most commonly used is using the catheter. And now come how to control how to enhance our repair. We have 4 techniques, factors in our surgery, the type of anesthesia, and we can use from technology some innovations from technology, and the basic science also provide us some modifiers to enhance our repair. Let's start with what we have as a surgeon. We start with the core suture. Core sutures, the strands which cross the fibers of the tendons, inside the fibers of the tendons. Number A, increasing the strands crossing the core suture, the cores of both ends will increase the repair tensile strength. However, this should be balanced also regarding the increased bulkiness of the repair and the resistance to glide. In general, now we can say that 4-strand repair appears to have adequate strength, especially if we increase this strength with peripheral sutures, as I will talk now. And this will avoid the complexity of 6, 2, or 8-strand repairs. There are wide range of repair sutures. Kessler is very known, modified Kessler. These are 2-strand suture, core suture, as you see, 2 sutures crossing the fibers. However, this is not, we consider that in the modern hand surgery, cruciate 4-strand repair in addition to peripheral suture, this is now considered the minimum repair strength, give us the minimum repair strength. We prefer braided suture material like Ethibond, Ticron, and so on. This is maybe stronger than the absorbable proline, for example. And we prefer 2.0 or 3.0 according to the size and the age of the patient. Increasing the size of the suture material will increase the strength. Ideal purchase of core suture is about 1 centimeter. 1 centimeter, you have to, this is the distance your needle goes through from the edge of the cut tendon till you get out of the tendon. Preferable not to be less than 1 centimeter. Why? Because this is increase the strength and gets away, because the edge of the tendon will be a site of softening later on. So when you get away from this, you will increase your repair site, especially in the period after the repair. Where to put your knot? Not whether inside or outside the repair site. If you put it inside, this may interfere with the healing site and weakens the repair. However, if you put it outside, also this may interfere with the gliding. So there is a controversy in this matter. However, the trend now is to put your knot outside. There is 2 configurations in your loop of because we can use crochet, or we can use Kistler, for example. And Kistler, there is a loop configuration when the transverse limb meets the longitudinal limb in Kistler, or the longitudinal limb meets the oblique limb in crochet. In this junction, this is a locking loop, and we can expect this is stronger, and this is a grasping rule. It surrounds loosely the fibers, but here it's locked around the fibers, and this is stronger repair. How can we attain this? Please notice here, if the transverse limb of the Kistler is deeper to the longitudinal limb, like this configuration, it will lead to grasping, just grasping. This is in contrast to what we see here. This is the locking pattern, where the transverse limb is superficial to the longitudinal limb. So what I advise, that the transverse limb in Kistler or in the oblique limb in the crochet should be proximal, meaning nearer to the end of the tendon, the cut tendon, and should be superficial to the longitudinal limb. Some suggest that to grip another, to have what we call the anchor point after the transverse limb or the longitudinal limb, to grip the tendon again. This will increase the strength of your repair. As I told you in the beginning, the vascularity in the tendon comes mainly from the dorsal side. And that's why in the beginning, we put our repair sutures in the volar side, in the superficial part, to get away from the dorsal blood supply. However, now we shifted to the dorsal and deep part. We put our sutures deeper, because we found that the blood supply mainly comes from diffusion and not through the blood supply in the tendon. And as you may consider that when we flex the fingers, there is a tension increase on the dorsal side. And putting the sutures on the dorsal side, this will lead to what we call the tension band effect. Putting the sutures on the dorsal side will resist the tendency for increasing the tensile strength on the dorsal side. This is how to strengthen your core sutures. The other thing in your technique, the peripheral suture. Peripheral suture, we take sutures on the periphery all around the tendon with thinner or with 5-0 or 6-0 suture material. And this gives us two advantages. In adding the tensile strength of our repair 10 to 50% and also smoothen the end. To repair the sheath to repair the sheath or not, this is a controversial and no clear advantages. Some claim that this will be a barrier to adhesion formation and rapid return of nutrition. However, it may be difficult or tedious in surgery and increase possibility for adhesions and restriction of gliding. It's a controversial and not yet. This is how to, this is an example for my technique. I usually start with the dorsal peripheral suture on the periphery because this is away from me using a thin suture material like 5-0 or 4-0 or 6-0 according to the site and size of the patients. And after finishing, you start with the core suture. Core suture, please consider that this is I will now have a bite in the other end, and this is the distance I travel, and this is what we call the purchase. Try to as I said, try to take your purchase about 1 centimeter from the edge of the tendon, and here I took the first limb, the longitudinal limb. This is I will show you how to do a crochet type 4-strand tendon repair. Now I took the longitudinal limb, and the longitudinal limb should be deep enough, and then I will take the oblique limb. The oblique limb should be proximal, nearer to the edge of the tendon, and more superficial. Why? As I showed you before, in order to make a locking loop technique. So please notice, I will take the oblique limb, proximal, nearer to the fractures, to the edge of the cut tendon, and in a superficial. And one thing also you have to notice that I divide the tendon, the diameter of the tendon, into 4 parts. I will enter the longitudinal limb in the first, or for example here, the fourth nearer to me. And then I will take the oblique limb to get out from the edge of the tendon in the middle part of the tendon here. Then I will enter the other end from the middle part to the last fourth, the farthest fourth on the other side, in order to take the oblique suture, as I will do now here. I will enter from this edge, and maybe because the time, here I get out from the other side, and then I will take my longitudinal limb on the other side. And this should be deeper, and again, I repeat, deeper and distant from the oblique suture, in order to make an oblique, a locking loop. Then I will proceed on the other side, continuing my 4-strand. Here I get on the other side here, and then I will return back, forming 4 strands crossing the core of the tendon. To put the knot inside or outside, as I told you, that this is a controversial. This is after I finished my repair. proximal or distal, please notice that the knot will be in the site, the first bite you took. So if you passed your suture first inside the tendon here, the tendon edge, you have your knot inside the tendon repair. If you started by biting the tendon, the knot will be in this site in the end, outside the tendon. So this will be, you should concentrate on this. To put it proximal in here or here, I consider if there is, where is the possible impingement on the pulley. For example, if I expect that the pulley, for example, we are suturing the distal end of the tendon, and here is pulley, the A4 pulley, the tendon will move in this way. So if I put the knot here, very distal, this will lessen the possibility of impingement of the suture on the edge of the pulley. So you have to manipulate according to what do you expect or what do you have in your injury. And finally, after I took the core suture, I put my volar peripheral suture, ending my repair. Please, I have some pitfalls. You have to know very well the anatomy, Camper's chiasm. This is the meeting again of the two superficialis tendon after the hole in the proximal end, in which the flexor digitorum profundus get out to continue its journey to the distal phalanx. You have to consider this anatomy very well. And the recommendation now, please, we don't like what we call the grandma kiss. We don't suture please, we don't like this. We like to suture your tendons very tightly. This will allow you to have a stronger repair. We don't like this grandma key. We like other types of kisses. To repair your flexor digitorum profundus, or both of them, profundus and superficialis or not, this is a very controversial issue. It's not, maybe not, we have not a clear decision or a statement about this. However, most of the trends of the literature and the hand surgeons prefer to prepare both of them outside zone, outside pulley, the second pulley, A2 pulley. If you repair outside the pulley, you can repair both of them. If you repair the tendon and the cut is inside the A2 pulley, maybe it's preferable to repair one of them, the flexor digitorum profundus. Please avoid what we call the dominoes effect. What do we mean by dominoes effect? Dominoes effect, that if you have, please pay attention to all the components of your repair. The peripheral suture, all sutures, your bite, your purchase, because any weak point in this may lead to gradual degradation and the cracking of your construct. This is maybe a hole in your structure, and then gradually it will crack, and there is a lengthening of your repair and the gapping and so on. So and this will start the dominance. So you have to give attention to all elements. The pulley system, this is the narrowest part of the fibro-osseous digital teeth, and it's a problem in our repair. And the recent trend, we should have what we call free gliding repair. In order, you have to check your repair, and the patient can flex completely his finger without any impedance from the pulley. If you have any problem with the pulley, please go and vent and release your pulley. Up to some consider sacrificing all A4 pulley if it will constrict your the motion of the tendon, you can sacrifice this provided that A2 pulley is intact. Try to vent as much as you can to ensure free gliding repair. This is very important. Another tip from Al-Qattan, Saudi Arabia, if you have a deficient distal stump, you can use a distally based volar plate, the volar plate of the distal phalanx. This is a fibrocartilage, and you can repair this to the distally based volar plate, and it's a very nice tip. So to summarize the surgical technique, the recent trends, at least 4 core strands, some now consider 6 strands are the minimum. However, 4 core strands and peripheral sutures are maybe, this is the minimum at least now. Increasing the suture caliber will increase the strength. Braided 3-0, maybe this is the best. Knots better outside, to be outside. Please, locking loop configuration, put your suture dorsally and use peripheral sutures and equal tension across all the strands. The other tip is the Wallant. Wallant, this is the new trend in tendon repair and fractures of the hand, meaning wide awake local anesthesia without using the tourniquet. We can use this mixture of anesthetics and epinephrine and sodium bicarb in order to anesthetize the patient. And this makes the hand surgery like dental surgery. The patient is awake, he can obey orders, but he's not feeling pain, and we can infiltrate our field with this mixture and waiting about 30 minutes, and then we can use it to repair and deliver and to do all what we want, and this is without the hazards of general anesthesia. And most importantly, the patient is awake, and we can test our repair, and after we finish, we can test our repair like this and ask the patient to move and flex and extend and so on. This is a tremendous improvement in the hand surgery. And it's very low cost without the hazards of anesthesia, and very helpful to adjust our repair. And please don't go out from your theater without testing that your repair with doing flexion and extension testing. There is impingement in your repair. Is the repair impinge on the pulley? Because we, as I said, we want free gliding repair. Anything hindering your motion, please cut it and get away. And in extension, if there is a gap, is your repair is strong enough to withstand this. Anything you corrected inside the surgery will save you from problems and very difficult problems and very difficult times outside the theater. Techniques, they from the innovations, some invented these connecting device to improve the repair. However, what they call Tenofix may be easier. However, it's not very popular and maybe also expensive to put it on both ends and try to repair. Biology, the basic science also is going, there is ongoing research to improve the repair side by using lubricant material to enhance the gliding of the tendon, and also exogenous growth factors to improve the healing and repair. And maybe the gene therapy has a role in improving our results. In conclusion, it's very difficult very challenging and very common. However, you should, it's very, needs meticulous and good technique in order to have a very good outcome. Also, the post-operative rehabilitation is very, very important, but for the time, I didn't include this. Thank you all, and thank you, Dr. Ashhab, and thank you, Dr. Ashraf. Thank you all.
Thank you, Professor Ahmed Naim, for this nice presentation. Now we go back to Professor Hussam Abu Dunya. He will talk about ulnar side wrist pain dilemma.
Dr. Ashraf, I think there's some questions to Professor Ahmed.
Okay.
In the question box.
There are a question from Ahmed Sulaiman. How can we detect position of finger on injury by history only?
Usually it is difficult. Some can remember the position, and some other patients, especially the young patients and the children, maybe cannot tell us what's the position. But you can expect this, and you can tell the parents or the patients that we may extend the incision proximally or distally according to what we will see in the surgery. If you didn't found your stump, the distal stump at the wound site, this means mostly it is distal, and this means it is cut in flexion.
Is there another question? Is there any difference in interfering of blood supply between locking and the grasping technique?
Actually, I'm not aware of this. I can't tell you precisely, but in my experience, I don't think that there's the locking suture affecting the blood supply to that extent. Of course, the grasping suture, we can expect logically that it will not affect the blood supply so much. But I don't think that the grasping sutures affect it to a significant level. Yeah.
There are another question, the common question: what's the difference between non-absorbable and absorbable suture?
There are many differences. Usually, in the literature, we prefer the non-absorbable sutures because it may keep the strength for a longer time, and the tensile strength is stronger than the absorbable, and we are afraid that the absorbable suture can be absorbed in a rapid time, and this will affect the repair. The advantage of the absorbable suture, like Prolene, actually, it is the sliding, can be easily sliding, and the handling inside the tendon is simpler than the braided suture. This is one advantage, and actually I use them in many occasions because this advantage. I know that the tensile strength may be a little bit higher in the braided sutures. Maybe these are the most common differences between them.
Okay, there are a question from Rifat. He asked about if there is possibility to repair of single slip cut of superficial tendon.
Oh, yes. Also, this is a matter of debate. As I told you, these are the tips, and this is a debatable issue. maybe to simplify this conflict, if you have a problem in of the cut injury in zone inside A2 poly, maybe it's simpler to repair only the flexor digitorum profundus. If your cut is outside and you feel comfortable to repair both of superficialis and profundus, please go on. If you felt that this is a bulky repair and the will hinder the gliding of the tendon inside the pulleys, okay, you can proceed with profundus and either a slip of the superficialis or only the profundus, according to what do you see in the inside the surgery. However, of course, if you can repair both of them, this is will be better in my mind.
The last question about how many size of the defect of the flexor tendon you can stretch, or you can accept a direct repair centimeter.
1 centimeter. Usually, what's written is 1 centimeter. This is the maximum we can accept. Otherwise, this will, if you tighten more than 1 centimeter, this will leads to what we call the quadriga effect, because you know the flexor digitorum profundus are connected, except the slip to the index. The other flexor digitorum, this is a one muscle with 3 tendons. So if you tighten one of them, this will hinder the full flexion of the others. So be careful of this. No more than 1 centimeter, you can advance the tendon. And what I show the tip of the technique of Al-Qattan, that to use the volar plate of the distal interphalangeal joint can be a solution to this.
Okay, thank you, Professor Ahmed Naim, for nice presentation.
You.
Now we will move to Professor Hussam Abu Dunya.
Start sharing. Thanks, Dr. Ashraf again, and Dr. Mohammed Al-Ashhab. And thanks for Dr. Ahmed Naim for this nice presentation, as usual from him. So I'm talking now about the underside wrist pain, which is a bit common, a problem we face. And as I said, it's the black box of the wrist, and have a lot of question trying to identify the source of pain around the underside of the wrist. And we're trying in this presentation to get like a systematic or structured way to lead us to the reason for the underside wrist pain. We can approach this through knowing the anatomy and then attacking the pathology for different structures of the anatomy. So the first thing, it could be a problem to the bone itself, which in acute settings would be a fracture. And the most common fractures on the underside of the wrist is the hamate, which be either the hook of the hamate or the body of the hamate, which sometimes be associated with a disruption to the 4th and 5th CMC joint with subluxation or even dislocation. The other common fracture is the ulnar styloid, which could be associated with a TFCC injury. We could classify the hamate fractures to 2 types, which was type 1 included the hook of the hamate, and type 2 included the body, which would be a coronal split or a transverse type. The other problem, it could be a problem to the ligament, which could include the leonotriquetral ligament injury or an injury to the TFCC, either a central tear or a peripheral tear. Other problems, it could be a problem to the joint, which include the distal radioulnar joint if it gets arthritic. The other joint is the ulno-carpal joint in cases of the ulnar impingement or a positive ulnar variance, which could lead to arthritis between the ulnar and the carpal bones. And the other joint also is the joint between the basiform and the triquetrum. There is tendons around this area, and mainly the flexor and extensor carpi ulnaris, and they can get inflamed and have a tenosynovitis, and even can have a stability in cases of the ACU instability. Could have a nerve problem, and the common superficial nerve here is the dorsal superficial branch of the ulnar nerve, which could be injured due to a laceration or even iatrogenic due to a surgery, causing a neuroma and painful side of the ulnar wrist. It's quite important to get a detailed history of the patient about the type of the pain, if he has any recent trauma, if there's any things which is aggravating the pain. And clinical examination should to get a good consideration if there is any laceration, which is maybe due to a previous operation or due to a laceration. If there is any deformities, which sometimes could be associated with ulnar plus or ulnar impingement syndrome, or even a dislocation of the DRUJ, or if there is any swelling, which sometimes could be a ganglion, even if it's a less likely region for having a ganglion here. We should palpate this side of the wrist, even polarly and dorsally, to check the tender point, even over the hook of the hamate, the basiform, the fifth and fourth CMC joint, and quite important to check the fovea point, which we can see on the right-hand side of the screen. And this is a point between the flexor carpi ulnaris tendon and the styloid of the ulna, and it's quite significant and pathognomonic for the TFCC injuries. Is there any other joint or parts of the body we should examine if patient presented with ulnar side wrist pain? Of course, it's not the ankle, but it's actually, this is a picture of an X-ray, which is familiar to every orthopedic surgeon. And classical teaching, we have considered to examine the knee if we see such a picture, because we know that the injury could start even on the medial side of the ankle, but it propagates through the interosseous membrane all the way up to the proximal fibula, which it exits. And we can consider the eccentricity injury of the forearm is similar to the this injuries to the ankle. So if patient has presented with ulnar-sided wrist pain, it could be contributed by the proximal radioulnar joint instability, and you have to examine the forearm and the elbow in the same time. We have to examine the range of motion in all direction, pronation, supination, radial ulnar deviation, and flexion extension. And there is some special tests for some problems, as we mentioned. So in case we suspected a hook of hamate, a resisted flexion of the and activation of the FDS tendons for the little and the ring finger, while the wrist in ulnar side position, this is put a pressure over the hook of hamate and can exacerbate the pain of the patient. To test the ligaments of the leonotriquetra, we have to use one hand to stabilize the leonate and the other hand to control the basiform triquetral mass, and with dorsally movement to this mass, the patient can elect the pain or even instability. The other test is the Nakamura test, which is a provocative test for ulnar impaction or a TFCC injury. While we hold the elbow in flexion and a full pronation of the forearm, ulnar deviation to the wrist, and with flexion extension, the patient will experience pain if he had any of these two problems. We have to check the DRUJ stability, and it's quite important to check it in full pronation, full supination, and in the mid-prone as well. This is because the TFCC ligaments consists mainly of the volar and the dorsal radio-ulnar joint, which are tight or lax in certain positions. So we can see that in supination, the dorsal ligaments would be lax and the volar would be tight, and the vice versa would be in pronation. Also, we have to consider that the distal radio-ulnar joint is not maybe not just unstable in the coronal plane, but also in the axial plane, as we discussed earlier. So the proximal radio-ulnar joint injury could contribute to the axial instability, as well as the interosseous membrane injuries. There's a test for the basiform triquetral arthritis. We're supporting the wrist with one hand, and with the other thumb, we glide the basiform over the triquetral, and this can elicit pain if a patient has an arthritis to this joint. And there's the synergy test for the extensor carpi ulnaris instability. When we ask the patient to actively do a thumb abduction against resistance, and this can activate isometric contraction of the ACU and FCU, and if the patient had instability, he could experience the clicking sensation as well as pain. And the ACU instability could be due to the rupture of the ACU subsheath, and these could be classified according to the site of the injury of the subsheath to type A, which is the rupture from the ulnar side, type C, which is a sleeve to the periosteum on the ulnar side, causing like a false pouch to the tendon to escape in. And both of these types are unstable in supination. And type B is the type where the subsheath is ruptured on the radial side. Have to look for the images, simply the X-rays, and the standard for the wrist is the BA and lateral, and you have to make sure that the BA is being taken with the shoulder abducted to 90 degrees and the elbow flexed to 90 degrees with full pronation. There is other views we could consider in different situations. So if suspecting a hamate fracture, a semi-pronated view could visualize the shear fracture more obviously. Also have to ensure that we have a true lateral view in these cases to assess if there is any subluxation or dislocation to the CMC joints. Also, the carpal tunnel view, which could help to visualize the hook of hamate fractures. On the BA view, we can assess the ulnar variance, and we can assess the consequences of that in cases of impingement with sclerosis or subchondral cystic changes in both sides of the ulnocarpal joint. We can assess the DRUJ instability from the X-ray if there is an obvious sign with widening space of the DRUJ, if there is associated base of the ulnar styloid fracture, or on the lateral view, we can assess if there is any incongruency with the ulnar head is not congruent to the sigmoid notch of the radius. Again, we can view also the DRUJ arthritis. We can see if there is any calcification within the TFCC, which could suggest a metabolic arthropathy like the pseudo-gout. And again, the semi-supinated views, which gives a better visualization of the basiform triquetral joint in cases of arthritis. We can consider a CT scan to visualize fractures in more obvious views, like in cases of the hook of hamate or subluxation or the dislocation of the CMC joints. MRI scan has a role in cases of a positive ulnar variance with ulnar impection syndrome. So we can see the changes on the ulnar corner of the leonate. And we can also assess the injuries of the TFCC, even if it's a central tear, like we see on the left-hand side, or if it's a avulsion from the fovea, which is associated with DRUJ instability, as we see on the right-hand side. And also in the axial view, we can review the volar and the dorsal radioulnar ligament of the TFCC and to assess if there is any subluxation there. We can see from the MRI and the arthrogram even if there is any leonotriquetral ligament injury. The ultrasound scan has definitely has a role, especially when we need a dynamic examination, like in cases with the ACU subluxation or instability, so we can assess the movement of the ACU outside of its groove. So there is also some other pathologies and injuries that could be away from the ulnar side of the wrist, but it's have a great effect to the ulnar side of the wrist. And the most important one of them is the distal radius fracture. So how many of us have seen a patient come with a distal radius fracture, which has been treated conservatively or operatively, and afterward the people or the patient is considering like an ulnar-sided wrist pain and have no problem with the distal radius at all. And this could be due to various problems. The first thing is even the patient has been healed in a non-optimal position, especially if there is a radial shortening, and this can lead to a positive ulnar variance with an imbection to the carpal bones. It's quite important to realize that the intra-articular fracture of the distal radius is not just the for the articular surface between the radius and the carpal bones, but also the sigmoid notch of the radius, which is the contact to the ulnar head through the DRUJ, and adequate reduction of this joint is important. Another common scenario is a laxity or instability to the DRUJ following the distal radius fracture, and it's quite important after fixing every distal radius fracture to assess the DRUJ stability in theater and to address if this need fixing as well, especially in cases we can see here like with a base of the ulnar cycloid fracture. Quite important also while fixing a distal radius fracture is to maintain the push-pull effect, and this is the mechanism which tightens the distal oblique band of the interosseous membrane, and radial translation of the distal radius can alter this mechanism and can cause a laxity to this ligament, as well as it can cause instability to the DRUJ. The other problems which could affect the ulnar side of the wrist is patient presented with a radial head fracture. And it's quite important with every patient presented with a radial head fracture to assess the distal radioulnar joint, thus to exclude any extended injuries through the interosseous membrane down to the DRUJ. And this is important to make the decision how to treat the radial head fracture, as that's need an adequate reduction and fixation of the radial head or even a replacement. And it would be the worst scenario to make a decision of excision of the radial head if the patient has an associated distal radioulnar joint injury. The last injury is the Gliazi fracture dislocation, and from the name, it's associated fracture to a dislocation to the DRUJ, and it's again quite important to have anatomic reduction to the radius and TROPS fixation, and that will restore the anatomy of the and the configuration of the distal radioulnar joint. And by the end of fixation, we have to assess the DRUJ stability and to consider fixing it if unstable, which is the more common. I hope I answer some question and make like a robust technique or pathway for diagnosing the ulnar side wrist pain. Thanks.
Thank you, Professor Professor Hussam Abu Dunya, for a nice presentation. If there is any question, we are wait for any question to Professor Hussam Abu Dunya. Now we will move to Professor Amr Mustafa. He will talk about elbow instability treatment guideline.
Assalamu alaikum.
عليكم السلام.
I'd like to thank I'd like to thank Dr. Ashraf and Dr. Ashraf for this nice subspecialty day. It was a pleasure really to hear it from the start, from the shoulder session. And I will present my talk about simple elbow instability, the treatment guidelines. Okay, so our ILOs is first to know the elbow stabilizers, and second to classify the simple elbow dislocation, and to know how to manage this simple elbow dislocations. Okay, so we will talk about this case, which I think many of us are seeing this case. The point is, the most junior resident is the one who see this case, and he's the one who first tried to treat it. So I hope that this junior resident are watching us now to answer two important questions. First, how we will reduce this elbow, and then the second, when we will rehab and how we will rehab this patient. Another question is, if the patient already come to you after he had a reduction in the emergency, and he came to you in your office with this X-ray, what would you do? And I think this is what we face. So this will be our ideas. So how we will assess this elbow, we will rehab, and if the management will differ if the patient was an athlete or non-athlete. I hope that we will, by the end of this presentation, answer these three questions. What's a simple elbow dislocation? What do you think? Simple elbow dislocation. I hope that it will be an interactive session so we can interact with the participant. But you can see that the X-ray on the left is completely simple. There is no fractures. And the one in the middle, we have a very slight waver of bone, as you can see. So is it simple or it's complex yet? And the third one on the right, we can see that we have already fracture of the radial head. So what is not simple elbow dislocation is the one on the right. So in a simple elbow dislocation, we can accept to have small fragments about 1 to 2 millimeters. Okay, so it is still simple dislocations. What about the classification of simple elbow dislocations in adults? Usually you have these three different patterns, as you can see. We could have a direct posterior, as the one on the left, or a posterolateral dislocation, as the one on the middle, or a posteromedial dislocation. Every one of them has different mechanism of injury and different injured tissue. So in order to think about this dislocation, it is a simple dislocation. We have to think what are the stabilizers for the elbow. We have a primary and secondary. The primary stabilizers for an elbow joint is what you see in the right figure. It is an ulnohumeral joint with both ligaments, MCL, and the or the lateral ulnar collateral ligament. So if this elbow dislocates, what does it mean? And the bone is still intact. This means that we have an injury to both ligaments, plus or minus affection of the secondary stabilizers. What are these secondary stabilizers? As you can see in the MRI, these are the muscles, the biceps and brachialis in the front, triceps in the back, which causing the compression forces. And as you can see on the right side MRI, it is a common flexor origin and the common extensor origin. A very nice thing from the previous view that, and I will repeat it later on, it is not usual that we will have an injury of the ligaments, but there is another subset of injury of the collaterals, which I think not many people think about it. It is a subperiosteal sleeve avulsion of the ligament. So the ligament is not cut, but it is avulsed, or it is elevated with the periosteum. So when we do a reduction, the ligament returns back to its tension. This is very important to know. Second, what should we know about any elbow dislocation? These items is what we will discuss. First of all, is the mechanism of injury. What do you think how this guy with this direct posterior elbow dislocation had this injury? Normally, there are two explanations, as you can see in this slide. Either this guy has fallen with the elbow in incomplete elbow extension, or he can fall in complete elbow hyperextension. We have two different ways and two different mechanisms of injury. In the one on the left, we have a valgus and external rotation force. So in such injury, usually the injured tissue started from the lateral with a posterolateral force, and it hinges around the MCL. It is what we call the circle of Horay that has been described by Audrey Scholl many times, and it was verified many times by cadaveric studies. On the other side, if the patient fall on hyperextension, this is the opposite. It is a reversed circle that has been introduced in 2012, where the injury starts from the medial side by the MCL, and it has been verified by different MRI views. So both theories have their own opponents. Another injury that we see, as we have described, we have three main different categories. It is the posterior dislocation, and this one, which is the posterolateral. It is not an uncommon dislocation. But in such cases, when we have a posterolateral dislocation, what explains the mechanism of injury is we have a distraction on one side and we have a compression on the other side. What does it mean at this case? Usually we have in such a case a distraction on the medial side, which will cause in turn injury to the medial structures. And on the other side, which is the lateral side, we will have a compression of the radial head on the capitellum with contusions. As you can see on this MRI, you can see that the lateral structures are completely intact, and it is only the MCL that is avulsed. What about on this injury? It is one of my patients that had a posteromedial or direct medial dislocation, as you can see here. If you think about this case, you have to think how much this radial head has been translated. And so in turn, the whole lateral structures have been injured. They had a distraction force. On the other side, the medial side, it's mainly translation. The medial side may be intact. As you can see in this MRI, the lateral structure with the whole common extensor origin is injured, as you can see in these black arrows. On the other side, you can see on the white arrows that the MCL is completely intact with the common flexor origin. So I think this mechanism will change our way of managing these patients, how we can, if they are irreducible or grossly unstable, how can we operate them? How can we approach them? Second, the assessment of such patient. If such a patient is coming to us in the ER, holding his hand, as you can see, with his elbow completely deformed, what's your action? I think some of the residents, when they see a patient like this, they will go directly to try to reduce it closely. But is it right? No, it's completely wrong, because we have first to do an X-ray and to see we are treating a simple elbow dislocation or it is a complex one. Second, if you have this X-ray, still you go directly to do a closed reduction in the ER. No, it's completely wrong. And the right thing, if it is possible to take this patient to the OR and do the reduction under sedation, followed by assessment of the stability, this is the ideal. And then assess the range of motion, and we will come to this part in a few minutes, how we will assess these patients. The second group of patients that are coming to our clinic after having a reduction 1 or 2 days post-reduction, they came to us in this form. The elbow is reduced and he has a good X-ray, but you can see that he may has bruising in his subcutaneous tissue and fascia. And what does this bruising means? This patient doesn't have a fracture. So most probably it is the fascia that is injured. And this fascia is covering the secondary stabilizers. And a contusion like this and a swelling in a patient with a simple elbow dislocations, most probably it is a gross instability with injury of the primary stabilizers, which are the ligaments, with the secondary stabilizers, which are the common flexor or common extensor origin. So we have to get great care of this patient, however they have a stable, good X-ray. But how can we assess these patients? Should we order an MRI? What do you think? MRI in a simple elbow dislocation, is it mandatory? No, it is not mandatory at all. And it's not nice to have a patient that is coming to you with an MRI showing an injury of the MCL or the LCL, and then you have to do a surgery. No. So what should we do in such a cases? First, we should know that MRI is controversial. Why? If we stuck to the MRI for our diagnosis of the ligamentous injuries, as we know, most of the patients will have a ligamentous injury. And so this will end with an overtreatment of such patients. But what will guide our treatment in such cases? It is the examination of the elbow stability at the time of the reduction. So cases coming to us after 1 or 2 days at our offices with previous reduction in the emergency, we have to assess them by doing an active range of motion. Because the passive is impossible. The patient will be in a pain and will have a pain inhibition of any motion. But we have to ask them to do an active range of motion. If it is possible that they can do a full active range of motion in all directions, what mean in pronation and in supination, then most probably this elbow is stable. And we have to order an X-ray in 1 week. But if not, or if they came with an X-ray that's showing a drop-off sign, as we will show, then we have to go to the OR to examine them under anesthesia. What we do under anesthesia, either for those patients that we have closely reduced them in the OR or came to us after 1 week with incomplete full active range of motion, we have to assess under the CR. And we have to assess the full elbow range of motion. We have to see the stability in full extension, beside to do a varus and volvus test. But what if the elbow is unstable in full extension? What should we do? What algorithm I used it to do is this algorithm, as we will state, but I have changed it, as I will show you. And I think most of us is still stuck to this algorithm. What if the elbow is stable in full extension? Then if this patient is non-athlete, okay, then the patient can go and do rehabilitation without any limitation, unrestricted active range of motion. But if he is an athlete, it's very important for all athletes to have a good MCL. So we have to assess for the valgus instability. And if the MCL looks insufficient, we have to operate this patient if he's an athlete. As you can see in such video with this patient, sorry. You can see how the MCL is. And so this patient, we have to is MCL. What if the elbow is not stable in full extension? What next? Usually we assess this patient in supination. And if not, we have to do pronation. What do pronations do? It locks the elbow. It stabilizes the elbow more. And so in such a case, we have to assess the elbow in extension. So if it is stable in more than 45 degrees, we can splint his elbow in an extension block. And he can start in an hinged elbow brace to do early active range of motion. But if not, and it is even unstable in more than 45 degrees of flexion, so we have to operate this patient. What about the results of simple elbow dislocation with this algorithm? We have a large number of stiffness in about 1/3 of cases. I think why? Because we limit them to hinged elbow brace for a long time, which results in stiffness, especially with a loss of the last few degrees of extension. We have a PLRI, which is posterolateral rotatory instability in about 10% of these patients, which usually need a secondary surgery. And in some studies, they showed that 20% of their patients can't return back to sports, which I think is a large number, especially elbow dislocations occur in young patients. So this result is not quite satisfactory. And this is why I try to search the literature to see what is new protocols are there. And I was very satisfied by reading this research article by Schnitsky in 2015, who tried to revise the whole patient that came to him or to his center with a simple elbow dislocation and have been treated conservatively to see what is the main idea or criteria that gives a low scoring in the Mayo elbow score, or by other words, a poor prognosis. He showed under all patients, he did a close reduction and examination under GA, as you can see. And in such a case, he tried to assess the elbow, not only in extension, but also to assess the varus valgus instability. And when the angle was less than 10 degrees, it's considered to be mild. And these patients with conservative treatment give a very good results and a very high Mayo elbow scores. But patients with moderate, which is more than 10 degrees, as you can see this intraoperative radiology on the right photo, where the opening is more than 10 degrees, these patients, most of them have poor prognosis, and a large number of them had or needed secondary surgery, which I think would change our protocol of treatment, not only to assess instability in full extension, okay, but also to assess the varus valgus degree of opening of these lines. And his conclusion is that worse outcome with the moderate joint instability, which means more than 10 degrees of opening. Gross instability occurs, and he showed that all patients with instability, means instability or drop of sign or dislocation, they all needed an open reduction. How we operate these patients, as I showed you, this patient with a direct medial dislocation of the elbow, which is an uncommon one. But in such patients, it is the circle of Horry that has explained their injury. And it is the mechanism of injury that explains our approach. So it's most probably started at the lateral aspect, goes with the capsule. You can see on this view, on the left up, when we opened the scan, we found the whole common extensive origin of the capitellum. So it is the whole secondary stabilizers that have been injured. And you can see quite well the translation that the radial head had reached. It reached to the lateral aspect of the trachea. And in such a case, we tried to repair the whole lateral complex with the LCL and the common extensive origin to have a stable. So then come the next question. After reducing this elbow and having a stable elbow, how would we rehabilitate this patient in order to avoid having stiffness in 1/3 of cases? A very nice protocols have arrived to show the difference between 3 different protocols of management. The one, as you can see, the A, when the patient is doing rehabilitation standing or sitting, it is a dependent position with the effect of the gravity. You can see that drop-off sign can occur. On the other side, the C, when the patient is doing his rehabilitation with shoulder abduction, as you can see quite well that this could affect the healing of the lateral collateral ligament with causing a varus stresses. And the best of the best is to do an overhead rehabilitation. And this is a nice study that have been by the Lee group in the United States, showing the biomechanical effect of the different types of physiotherapy during a dependent or overhead, and showing that the overhead helps more to have a compression over the elbow joint and has no effect on the MCL or LCL and helps having them healing with no tension. And this recommends to have an yearly overhead activities with no splinting. So a take-home message is to know quite well that the mechanism of injury helps to understand the possible injured tissue, and that role of MRI in cases of simple elbow dislocation is quite controversial, and that the main part in the decision in simple elbow dislocation is the examination at the time of the reduction. And if during assessment under C-arm we have a moderate joint instability with more than 10 degrees of opening, usually this patient will have a poor outcome and surgery is recommended. And in such cases, either non-operated and early overhead rehabilitation protocols will avoid having stiffness. Thank you.
Thank you so much, Professor Amr Mustafa, for this interesting presentation. واسمحوا لي بقى اقدم النكست بريزنتر هيبقى اخونا والزميل العزيز واستاذنا الفاضل Professor Ashraf Abdelaziz. Professor Ashraf is a great professor in hand surgery. He's from Al Azhar University, and he will speak about Klein-Pox disease. Thank you so much for all of you.
Thank you, Professor Muhammad Al-Ashhab, for a nice day. يرفع الله الذين آمنوا منكم والذين أوتوا العلم درجات. صدق الله العظيم. Today we will talk about Klein-Pox disease, staging and the treatment advances. This female patient, 22 years old, what's your think about this X-ray, AB and lateral views? There are here leonetomalacia, or what's called Kienbock disease. Which grade of this Kienbock? I think it's grade 2. Kienbock disease, it's osteonecrosis or leonetomalacia of the leonate, can lead to chronic and debilitating wrist pain. We have to know the most of patients with Kienbock disease showed an ulnar minus variant. What about the biomechanical change or pathoanatomy? If there are bone necrosis of the leonate with trabecular fracture, it will lead to collapse and fragmentation of the leonate. Then the carpal height will be decreased and the scaphoid will go to hyperflex and the triquetrum will go to hyperextend. What about the symptoms of the patient with Kienbock disease? The pain at the center of the wrist, stiffness of the wrist. Sometimes there are some swelling of the wrist, localized tenderness at the leonate fossa, and there are some limited range of motion, and sometimes the complication, the patient will come with a complication like extensor tendon rupture. The main investigation is the clinical, then X-ray is very important, then MRI, the lastly and the more recent is arthroscopic investigation or arthroscopy. MRI is very important to diagnose type 1 and type 2, and very important to show it the osteoarthritic changes of the wrist joint and the arthritic changes of the cavitate, and may show it ulnar minus or ulnar positive. What about the staging system? Type 1, it's a linear fracture and not shown in X-ray. It's detected by MRI. Type 2, there is density abnormality of the leonate on X-ray without any collapse or arthritic changes. But also the dilemma, it will be in stage 3. Stage 3A and stage 3B. Stage 3A, without collapse of the carpal bone, without collapse of the leonate, without change of the position of the scaphoid. But in type 3B, there are a change in the position of the scaphoid, and it will lead to hyperextension of the scaphoid and lead to a change of biomechanics of the whole carpal bone. Stage 4, extensive osteoarthritic change of the wrist joint. What about the algorithm and the treatment option? The treatment option is 3 options, only 3 options. The first option, unload the leonate. The second, promote revascularization by vascularized graft or by direct vascularization to the leonate. Or the third option, salvage procedures. So this table, 4 algorithms and different option of treatment of the Kienbock. In type 1, just immobilization and the medical treatment. In stage 2 and the stage 3A, with very important negative or neutral ulnar variance, you can manage it by radial shortening osteotomy or ulnar ulnar lengthening. But in stage 2 and the stage 3A with positive ulnar variance, you can go for cavitate shortening or revascularization of the leonate or radial wedge or dome osteotomy of the radius without any shortening of the radius, or combination of one of two of this solution. But the main problem and the main difficulty in type 3B. Type 3B, we will go for salvage procedures, limited wrist arthrodesis, scaphotrapeziotrapezoid arthrodesis, or scaphocavitate fusion with or without leonate excision, or radial shortening osteotomy still have a chance in the new paper, or proximal row carpectomy, and you have to ask your about weak grip after this procedures. And the very important contraindication of proximal row carpectomy, it's affection of the articular surface of the cavitate. In stage 4, with advanced osteoarthritis of the wrist joint, you can you have two solutions: wrist arthrodesis versus wrist denervation. Go back for treatment options. There are factors to consider when deciding on treatment of the Kimbo. What is the stage of the involvement of the leonate? What about the ulnar variance? The patient age and the functional level, and what about arthritic changes of the wrist joint? There are procedures to unload the leonate. The most common options, the radial shortening or cavitate shortening, but the radial shortening in case of ulna minus or neutral ulna, and the cavitate shortening in the ulna positive. Radial shortening in early disease in type 2 and type 3A with negative ulna minus. You can make shortening up to 4 millimeter. More shortening can lead to ulnar impaction syndrome and the impingement of the DRUG. There are different options for radial shortening by T distal radius plate, or by small DCB, or by dorsal approach, and there are different procedures by shortening and fixation by headless screw or malleolar screw, by make a distal approach and metaphyseal osteotomy. All of this technique have advantage and the disadvantage. You have to consider this advantage and disadvantage, and your experience is a very important factor. So this is my technique by shortening by small DCB. You can make a 2 drill and only fixation by the near cortex by 2 screws, then make osteotomy and shortening for 3 millimeter. Then after that, you can make by this screw a compression 1 millimeter. Then after that, you can make a compression by 2 different screw, 2 far screws. and make more and more compression. It has advantage and disadvantage of this procedures. The advantage, you can control the rotation of your fixation, and it's have a very short time. And its disadvantage is you have to make bending of this plate, and you have to make more distal position of this plate, and it can make impingement to the flexor pollicis longus. This female patient with chronic wrist pain and ulna minus grade 2 Kienbock disease, this MRI, this after shortening by small DCB, and as I said, this disadvantage of this plate, you have to make it near to the joint to make the distal osteotomy between the metaphyseal and diaphyseal bone. This is another case, and this follow-up after 1 year. The capitate shortening, it's an option for the treatment of Kienbock disease with ulna plus, and have a different option of capitate osteotomy by transverse osteotomy or L-shaped osteotomy, or a different type of capitate shortening. But all of this have advantage and disadvantage. But the main important option for the main important requirement for this option is small osteotomy, 2 millimeter osteotomy, to make a shortening of the capitate. This case example of a male patient, 23 years old, with chronic wrist pain, and the ulna is neutral or positive. So it's managed by capitate shortening, and this after follow-up. And in this patient, I fix by 2K wire. It's easy and simple procedures and not expensive. Vascularized bone graft from dorsal distal radius through third, fourth intercompartmental bony graft with vascularized by dorsal branches to the intercompartmental graft, or volar graft by pronator pedicle graft for revascularization of the leonine. There are another procedures of direct revascularization by, you can cut a vein or artery and make as a pedicle through the leonine. This is the salvage of procedures of the one of the salvage procedures of the Kienbock disease. It's Kienbock disease with type 3B. It's scaphocapitate fusion with leonate excision, and this is the best procedures by excision of the leonate and the fixation of the scaphoid with capitate. But there are very important point in this technique. You have to make a joystick dorsal key wire through the distal part of the scaphoid, then make a reduction of the volar tint of the scaphoid. Then after that, you can fix by 2K wire or by 2 Herbert screw or one Herbert screw and the K-wire, but this is a simple procedures for fixation. With or without graft, I think there is no difference between two methods of fixation, and there are dilemma about excision of the leonid. You have to excise the leonid or you haven't excised it. But in my opinion and my theories, the leonid, it is a dead bone, and it is the main cause of the limitation of the dorsal extension of the wrist joint, and it is the main cause of synovitis and pain of the wrist joint. So in my opinion, it's the main important technique to excise the leonid, but there are another technique, make a limited wrist fusion without excision of the leonid. So scaphocapitate fusion prevent migration of the capitate bone to empty area after leonid excision. And the scaphocapitate fusion it have another benefit because it's there are 3 columns of the wrist joint. There are 3 columns of the wrist joint. So scaphocapitate fusion is a limited fusion between the first column and the second column. There are a very important point you have to discuss to the patient the limited wrist fusion or proximal root carpectomy or any method of wrist joint. It's to decrease the pain and increase the grip strength, but no improvement of the range of motion. يعني مستوى الحركة بتاعك مش هيتحسن قبل العملية عن بعد العملية، لكن احنا بنعمل العملية for pain and grip strength. This is a case of Kimball disease. You have to see this flexion position of the scaphoid and the leonid is very condensed with good wrist and the radioscaphoid and the articular surface of the capitate. So in this patient, this male patient, 60 years old with Kimball disease, and he came to the clinic with drop finger, and this drop finger because of Kimball disease. You have to see in this lateral position, this is a leonid excess bone, and this is the cause of pain and the cause of rupture of the extensor tendon. And you have to see this after exposure, there are here rupture of the extensor tendon. This is post-operative after 8 months. This is another case, female patient, 35 years old. The condition starts 3 years ago, limited range of motion. This MRI. You have to see here, there is no arthritic changes of the radioscaphoid. This after fixation by 2K wire and the excision of the leonid. This after 1 month. This after 3 months. The proximal root carpectomy, it's one of option of the treatment of the stage 3B, and you have to consider the articular surface of the capitate, and you have to consider with the disadvantage of this procedure about theories of it's a short time operation because after a long time it will go for advanced arthritic changes of the wrist joint. So the new operation and the new techniques of the proximal row carbectomy and make a soft tissue interposition of the wrist joint to prevent the complication of the proximal row carbectomy. Denervation of the wrist joint to one of the options for a long time of the wrist without arthrodesis. There are some people it's not agree with total wrist arthrodesis, and in this case we advise to make a total wrist denervation. One of the wrist denervation is neurotomy of the distal part or articular part of the posterior interosseous nerve and anterior interosseous nerve. The other salvage procedures is total wrist arthrodesis, especially in middle age and heavy walker male. Take-home message: Kienbock disease, it's uncommon but debilitating condition. The treatment option depend on the condition and the stage of the lesionate and ulnar variants. Scaphocapitate fusion is an effective procedure for treating Kienbock disease grade 3 B and C. This procedure is associated with significant improvement of the pain and the grip strength, no improvement of the range of motion. And thank you. Now we will move with Professor Amr Isa, and he will talk about OATS, osteochondral autograft transfer surgery in hand surgery. You are welcome,
Yes.
Professor Amr Atif, Amr Isa.
Amr Atif Isa. Do you hear me, Professor?
Yes.
Yeah, thank you. Thank you so much, Professor Ashraf. Thank you so much, Professor Al-Ashraf, for having me on this wonderful webinar. I'm really honored and humbled to join you guys, to join this outstanding faculty. I'm really...
Dr. Amr,
Yes.
I'm so sorry. I have a technical problem in the laptop. I'm joining from my iPhone. I'm so sorry, Dr. Ashraf. I had a technical problem.
No problem, sir.
No problem,
Thank you
sir.
so
We
much
hear
for you and for Dr. Amr. Thank you so much, sir.
No problem. So I'm really fortunate to have the last presentation in this webinar on Friday night. So I'm gonna keep it really short and sweet. Do you and you can see me now, don't you? So I'm gonna talk about the oats in hand surgery. So I have no conflicts of interest. Oats is a product from the firm Arthrex. I have no financial ties to Arthrex to declare. I work as a consultant for orthoplastic surgery and hand surgery, peripheral nerve surgery in the University of Heidelberg and in the clinic, in the Big Clinic in Ludwigshafen. By the end of this talk, in these 10 minutes, I'm gonna define what are the oats. Why are oats really attractive option in reconstructing the cartilage injuries in hand and wrist surgery? What does the evidence say when it comes to the oats, of using oats in hand surgery? And I'm gonna wrap it up and explain the whole thing in using a couple of examples. We, as orthopedic surgeons, know what the meaning of oats is, but in the hand surgery community is full of plastic surgeons and general surgeons who don't have that orthopedic background, and that's why we've been trying to popularize the concept of oats and make it a little bit popular in the hand surgery community here. So what are the oats? Oats stands for osteochondral autograft transfer system. It's not the oats that we usually eat for breakfast or for losing weight or building muscles. Initially developed in 2017 for knee procedures as described by Sherman, and by the early 2000s it became a well-established technique used widely in the knee joint. How does it work? It's a really elegant technique. You resect the cartilage defect and harvest a really size matched cylinder. It matches the size and the contour of this defect, and you impact this graft in the press fit fashion, so that it fits nicely into the defect without the need of using osteosynthesis. So that's why it's really an attractive way of reconstructing the cartilage. It's you reconstruct like with like. You don't need the osteosynthesis. Given the fact that it's really a press fit fashion, it provides an immediate stability, allows immediate motion, and fast recovery as well. So it's not been using in the knee itself. It's been using as well in the shoulder, in the elbow, and in the ankle joint. So the literature is really full of positive reports and encouraging results when it comes to using the oats in the orthopedic surgery world. But what about the hand and wrist? My team and I conducted a systematic literature review that's been published a couple of days ago in the Annals of Plastic Surgery. We've gone through the 1,700 articles and fetched for the articles that have been reporting the use of oats in reconstructing the cartilage injuries in hand and wrist surgery. And finally, our systematic review boiled down to 13 studies that were analyzed and summarized. Comparing the hand surgery literature to the other literatures, it's really a humble number, 13 studies only. It's not that much compared to the knee surgery literature or the shoulder surgery literature. In these 13 studies, the main donor site was the lateral femoral condyle. Medial femoral condyle was reported as well in one study. The hook of hemihamate graft using oats from the hemihamate graft was reported in one surgery, in one article, and using the oats from the lunate has been reported as well in one article. And the sites where these oats cylinder were used were basically the middle, the PIP joints, MCP joints, to reconstruct the lunate fossa and the capitate or the proximal pole of the scaphoid. In our systematic review, we've went through the indications, went through the donor side issues that are associated with harvesting these oats grafts. We've shed a bit of light on the difference between open and arthroscopic techniques of harvesting, whether autografts really provide more advantages against the allografts. I'm not gonna go through all these issues in our talk, but I'll be more than happy to share our systematic review with you guys if you wanna have it. So I'm gonna show you some examples of how to use the oats in reconstructing cartilage in hand and wrist surgery. So starting with this female, 20 years old, destroyed lunate fossa in a Kienbock's disease. We've seen the excellent ways of treating Kienbock's disease with Professor Ashraf Abdelaziz. In this case, in this young lady, we've done the arthroscopy. We do it in a regular basis in all key cases of Kienbock's disease to just do an assessment of the cartilage and document the Grigg and Bain classification using the arthroscopy. And as you see here in the picture in the middle, that was the picture of the lunate fossa with complete loss of the with the complete loss of the cartilage on the lunate fossa. So that was a problem in this young lady. So we couldn't have been able to provide the proximal carpectomy, for example, given the fact that the fossa, the lunate fossa, is really destroyed. So after exploring the wrist joint, as you see here in this picture, this is the lunate fossa, the destroyed lunate fossa, and we've resected the scaphoid in the setting of a proximal carpectomy as well, and then we've taken this cylinder from the concave surface of the scaphoid and implanted that Oates graft in the lunate fossa. So that was basically using the Oates from the resected proximal carpectomy to reconstruct the lunate fossa. And these are the results after 3 months. One can appreciate here on the side view the healing of these Oates grafts nicely in the distal radius, and these are the results on the right side, the functional results of this surgery. As Professor Ashraf Abdelaziz brilliantly said, the goal of Kienbock's surgery is really to reduce the pain, not to improve the motion. And this what we've seen as well in the patient-reported outcomes reported after this case. And if you see here at the end, this is the visual analog scale. Preoperatively, there was a significant reduction of the pain level after doing this surgery. This is another example of destroyed cartilage as well in the setting of a Kienbock's disease as well. Professor Ashraf, I have a couple of cases of Kienbock's disease. And then this case was done elsewhere with removal of the lunate and putting this pyrocarbon implant as a spacer to compensate for the absence of the lunate part. That, as you can see here on the right side, it was dislocated, and we had to remove it. And when you see here on the left side, on the left-hand picture downwards, you can see this ulcer on the capitate head. And we've reconstructed that the same way by removing the proximal row and using the convex surface of the scaphoid as the donor site for reconstructing the destroyed head of the capitate. And this is the cylinder that we've taken in this case. And these are the radiological and functional results. One can appreciate here the complete consolidation of these Oates grafts into the capitate bone, and these are the functional results. This is pretty much a decent result, and the patient was able to return to his sports activities and to work. We wanted to really use the Oates not only in these small cases. We do a lot of complex reconstructions, especially in the pediatric population and in adolescents. So we just wanted to push the borders and improve or increase our utilization of this oats technique. And this is one of my cases in 11-year-old girl that sustained a distal radial fracture and complicated down the line with resorption of the radiolunate articulation. And with loss of the articular surface from the at the at the articulation between the distal radius and the lunate, as you can see here in this upper left picture. And I'm really great fan of doing 3D reconstruction and 3D printed guides and implants. We've done the planning on the right side. You can appreciate here the preoperative planning. We've just wanted to reconstruct the destroyed cartilage and osteochondral parts with osteochondral grafts from the MCP joint of the second toe. I'm not going to go through the details, but if you can see here on the right side on this picture, this is how I harvested the oats, the oats cylinder from the convex surface of the MCP joint of the second toe. And on this picture on the right side, you can see here the lunate, how it's really nicely reconstructed using these oats grafts from the metatarsal head of the second toe. And on the left side, at the bottom of the slide, you can see the post-operative CT 3 or 4 months, I think, down the line with complete osseous integration of these oats grafts. It's really nice. You can go crazy with the indications, and that was our goal of popularizing this nice technique, just to expand the understanding of the oats and just push the borders in the hand surgery world. And these are the functional results. It's really nice results, pain-free. The patient was able to return to sport and do every activity she wanted to do. She really likes to dance as well. She could dance as well, despite having this surgery on the foot. That was as well, she was pain-free as well on her foot. So as a take-home message, oats is a really biological ideal replacement of a destroyed cartilage. You replace like with like. You have a press-fit fashion of infixation. You don't need an osteosynthesis, and you allow for early motion, early recovery. Oats, I think it's the forgotten art in reconstructing the cartilage. It's not so popular in the hand surgery community because we have a lot of in the hand surgery community is not only orthopedics or orthopedic or trauma surgeons. We have a lot of plastic surgeons and general surgeons who are not so familiar with these oats techniques. But I think we have a lot of the oats technique has a lot of potential in the hand surgery. We just need to explore it and try to help our patients with some innovative techniques to provide them with more function and try to reconstruct the cartilage and stay a little bit away from the limited fusion, because a lot of them, especially the young ones, really need mobile joints, and that would be a great help and a great improvement of their quality of life. Thank you so much.
Yeah, you are muted, Dr. Ashraf.
I have mute?
Yes.
Yes.
Thank you, Professor Amr Atif Isa, for this nice lecture and nice presentation. There are 2 questions to Professor Amr Mustafa.
First of all, sir, please, I have a question to Dr. Amr Isa.
Yes, sure.
Thank you so much for presenting this unique technique and marvelous technique, sir. And I want
Thank
to ask you if you have any experience in ACI, autologous chondrocyte implantation, in cases of cartilage defects of the hands, because I was in Keele University and Oswestry in UK, and they practice this technique on a large scale, but for the knee. But I want to ask you, do you have an experience, sir, for cases with cartilage defects in the hand?
Well, thank you so much. This is a really nice question. We've been I've spoken with with a lot of surgeons that do all these techniques of harvesting the part of the cartilage, sending it to the laboratory, make some cartilage sheets and return it back and implant it again in the knee joint. That's what you've mean.
Yes.
This technique is not allowed yet in the hand surgery in Europe, so we're not allowed to use it. It's a brilliant method, but it's not allowed to. It's only allowed to be used in the knee surgery.
In the knee, yeah.
But
do you
in the
think,
hand
sir, in the
surgery,
future it can be allowed in the hand?
Sorry, what's one?
Do you think in the future it can be allowed in the hand?
Well, we're gonna see. We have to push the borders of this technique as well, because I think it's a decent technique as well. You will only take a part of cartilage and you can cultivate it. I think it has a good future, but I think we hand surgeons need to push that forward.
Yeah, thank you so much.
No problem.
Professor Amr Ali. Professor Amr Mustafa. Okay. There are two questions for you. The first question, when you decide a surgical intervention for neglected patient with posterior elbow dislocation. Professor Amr?
Yeah, I'm sorry, the connection was unstable.
Yes.
Sorry. Yeah, I didn't hear the question. Can you repeat it?
Yes. When you decide a surgical intervention for a case of neglected elbow dislocation.
What do you mean by neglected?
I don't know. Maybe he want to ask about if there is a limited time to intervention with neglected case.
Yeah, because neglected cases of dislocation,
yes,
is a complete different. Yeah, I have few presentation on these cases, and I have some experience in it. Neglected cases are cases that came to you after a long time of dislocation, more than 3 months.
Yeah.
It is similar to these cases that have been presented by our colleague from South Africa in shoulder dislocation. It is usually in neglected cases, you have two problems. It is not only a problem ligamentous, but usually there is a problem bony that you have to take care of. Usually in most of my cases of neglected elbow dislocation, I have to reconstruct the coronoid beside reconstruction of the whole ligaments, okay, the MCL and LCL. And usually I do it by box technique that has been described by Audrey Skoll and Van Reed, I think 2012. So I think it's a different entity. And thanks God that it is not much cases, because it is a difficult cases.
You use a posterior approach, or a extended posterior approach, or lateral and medial approach in neglected cases?
No,
you have a connection problem.
Usually these cases, when they are neglected, you have much fibrosis inside the joint.
Yes.
And the first thing, usually we do, yeah, you hear me now?
Yes.
You hear me?
Yes.
Okay. Usually in such cases, we go through an extensile
الصوت راح تاني يا دكتور عمرو. Now we can close the session. Professor Ashab.
Thank you so much, Professor Ashraf.
Hello?
Yes, please, Dr. Amr, please.
Yeah.
We can hear you.
مشكلة في الكونكشن.
Okay.
You have a connection
So
problem,
we
Pierre.
use a posterior sensile approach followed. I've changed the place. Okay, sorry.
Yes. There are difficult problem of the posterior elbow dislocation in neglected cases. I think it's have a lot of discussion about approaches and how to deal with it. Now I have to thank my eminent Professor Yasser Al-Safuri, Professor Ahmed Naim, Professor Hussam Abu Dunya, Professor Amr Mustafa, Professor Amr Isa for joining us in this meeting. Lastly, I have to thank my eminent Professor Muhammad Al-Ashab for his excellent work and achievement of our Egyptian Society Association. And I want to thank all participants and my colleagues for sharing us for this event.
Thank you so much, Professor Ashraf, for your effort to make this great collection of professors from all over the world. Finally, I would like to say to all of you, many thanks to all our eminent guest speakers from Egypt, from South Africa, from Germany, and from UK, and for our attendees. Now we come to the end of the course, the Speciality Day. After 1 year of many specialty days, all the days are present and uploaded on the Egyptian Orthopedic Association YouTube channel. This is the 6th year of our online educational course sponsored by the Egyptian Orthopedic Association. هو احنا هنتوقف لمدة شهرين عشان نجهز ان شاء الله لمؤتمر جمعية جراحة العظام المصرية 77 اللي نأمل تشريف كل يعني اخواتنا واساتذتنا وزملائنا الافاضل فيه. هو المؤتمر ده ان شاء الله هيكون مؤتمر انترناشونال فعلا زي ما يعني بيقول الكتاب. احنا عندنا فول داي سيكو داي هيبقى فيه 2 مين سيشنز من السيكو، هاف داي اي او هيبقى سبونسرد بالاي او هيبقى على الفراكتشر بيلفس، وهيبقى المودريتورز والسبيكرز فيه بروفيسور بيتر جانودس من انجلترا وبروفيسور فيفيك تريخا من الهند. هيبقى عندنا اكثر من 20 ورك شوب سبونسرد من ومودريتد ب بروفيسورز من الصين ومن الهند ومن ساوث كوريا ومن انجلترا ومن المانيا ومن فرنسا. ويعني فعلا هيبقى في تجمع كبير جدا من الانترناشونال جيست سبيكرز. في فريق كامل جاي من الصين، اكثر من 25 بروفيسور جايين من الصين في سبيشال جروب. وان شاء الله هنبدا فعلا نتجه towards the east ونشوف الخبره في الايست. هيبقى في سيشن على التي سي ام traditional Chinese medicine وهنشوف الاكسبيرينس بتاعتهم. وانا شفتها في الصين، انا فيزيتنج بروفيسورز في 5 جامعات في الصين، فشفت الاكسبيرينس بتاعتهم في بالنسبه للاورثوبيدكس في التي سي ام. ان شاء الله نامل مشاركه حضراتكم جميعا في المؤتمر السنوي لجمعيه جراحه العظام المصريه اللي بنعتبره العرس السنوي للجمعيه. ان شاء الله بعد نهايه المؤتمر هنبدا another course educational course، هيبقى كورس جويند ما بين مصر وانجلترا والهند. ولو اي حد من الزملاء في المصريين في اي مكان في العالم يحب يجوين he is more than welcome. Thank you so much for all of you and I hope to see you in the upcoming 77th conference of the Egyptian Orthopedic Association. Thank you ونشوف حضراتكم على خير. السلام عليكم.
السلام عليكم.
السلام عليكم.
السلام